Okay, so Dr. Karagesian here, or Dr. Greg, or Greg, whichever one's easier. And we're going to move on and talk about gastrointestinal diagnostic procedures. Okay, so we'll start off with a bit of a review of the gastrointestinal system. We'll go through the different parts again, and then we'll move on and discuss different diagnostic procedures and tests that we can perform on the gastrointestinal tract. Okay, so we're going to start off talking about gastrointestinal diagnostic procedures. So how can we visualize different parts um, of the gastrointestinal tract based on symptoms that patients are having? So if someone's having rectal bleeding, and we want to look inside the colon. Well, that's going to be with a colonoscopy. Or if someone has severe constipation or they have a significant change in their bowel habits, that's going to be with a colonoscopy, right? Looking for the site of bleeding, looking at why they have a change in their bowel habits, in particular, looking for colon cancer. So colonoscopy, an upper gastrointestinal scope or an esophagogastro duodenoscopy. That's too long. So upper GI scope. Uh, why? Well, we want to look for disease states based on symptoms. So if someone vomits blood, well, let's have a look at their esophagus, their stomach, and their duodenum. If someone's losing weight and they have abdominal pain, or they're not able to eat anymore because they fill up really fast with food and they don't feel good. Well, let's look in their stomach to see if there's an ulcer or if they have a gastric cancer. Okay, so it's for an assortment of symptoms, and we base which scope is to be done based on those symptoms, right? So if we think it's a lower intestinal issue, a colonoscopy is often um, done. If it's an upper intestinal issue, such as vomiting blood, epigastric pain that we think might be a gastric ulcer or a duodenal ulcer, an upper scope is done. If we want to look at the bile ducts and the pancreatic ducts, we can use something called an ERCP, which is a scope that can put dye into the biliary tree to visualize the bile ducts and the pancreatic ducts and the liver as well. Okay, so it really just depends on what test do we think we need. If we just want to look at the sigmoid colon, we can use a little tiny scope called a sigmoidoscopy. So we don't have to do a whole colonoscopy if we think the problem is in the sigmoid. Okay. Okay, so a bit of a review here from pathophysiology and A&P about the digestive tract. In actual fact, the next slide, I have an enlarged image of these two. So let's just look at this in general first. So the gastrointestinal system is about 23 to 26 feet in length. Okay, most of that is actually going to be the small intestine, right? But really, the digestive tract starts at the mouth and finishes at the anus. Okay, so you have mouth, esophagus, stomach, small intestine, and there's three parts to the small intestine that we'll review. The large intestine, which is the colon, large intestine and rectum is the colorectal area, and then the anus. Okay. Accessory organs, I don't like calling them accessory organs because they're critical to life, especially the first two. Not so much the gallbladder, but the pancreas, which is an organ deep deep in the abdomen towards the back, and the liver, which is in the right upper quadrant. Okay, and of course the gallbladder, which stores bile and drains into the biliary system following a fatty meal to help with digestion of fat. Okay, and we'll talk about that as well. Okay, so what are the functions of the digestive tract? So chewing and swallowing. So chewing in the mouth, really important. It's the first area where there's mechanical breakdown of food, right? There's also chemical digestion that's occurring. So there's mechanical breakdown of food in the mouth, and then there's some amylase that's in your mouth that will start to break down starches and carbohydrates, right? So your salivary glands secrete amylase. And then there's the swallowing reflex, okay, which packages the food as a bolus towards the back of your throat. And then there's a swallowing mechanism, which properly gets the food into the esophagus and prevents aspiration into the lungs, right? And that involves not only the muscles of the pharynx, but also the epiglottis that closes like a flap over the vocal cords and the trachea to prevent aspiration. Okay. And then by peristalsis, the esophagus moves the food towards the stomach, right? You can actually eat upside down if you wanted to, because the esophagus has peristalsis, and the food will still make it to the stomach because of these muscular contractions of the esophagus. Okay. So what other functions? So chewing and swallowing, breakdown of food, that's digestion, right? The stomach has chemical breakdown and mechanical. So the stomach churns the food with its muscle layers. It also has chemical breakdown of food. So once the food is broken down, which is typically the vast majority of food breakdown, so digestion occurs in the small intestine, right? So you have amylases for carbohydrates, you have lipases for fats, and proteases for protein breakdown. Okay, protecting the system from bacteria. So you have a pH in your stomach of about 3 to 5, which is really acidic. So that protects the gastrointestinal system from bacteria to enter and invade the gastrointestinal tract. Okay, in terms of nutrient absorption, well, that's the process that follows digestion, right? So there's digestion of the food material and breakdown, and now there's absorption. The vast majority of absorption occurs in the small intestine, right? So it has villi, it has microvilli to increase the surface area of the small intestine, and the cells allow for absorption of the digestive food. So typically it's amino acids or tiny peptides that are crossing into the cells, and then the breakdown of carbohydrates into simple sugars such as glucose also gets through the cells, and they get transported to the liver through the portal venous system, right? So nutrients typically get to the liver as a screening organ before they get into the bloodstream. The only exception to that is certain lipids. So fats, triglycerides get absorbed, but they go into what are called the lacteals. And the lacteals send the fatty acids into another system called the lymphatic system, and the lymphatic system accumulates these triglycerides. In actual fact, the lymphatic system drains into what's called a thoracic duct, and the thoracic duct drains into a vein, and then that gets into your venous system. Okay, so And if you were to actually see the fluid that's in the thoracic duct, it's very milky because it has triglycerides in it. Okay, so that's the one exception of how nutrients get into the system. That triglycerides and fats can get into, they can bypass the liver and get into the system through the lacteals. So really think of the thoracic duct as a drainage tube of the lymphatics that takes this this milky solution called chyle or lymph, and it takes it and returns it back into the venous system. Okay, and so this system drains the lower legs, the abdomen, the left chest, the left upper arm, and the left face and neck. And this thoracic duct drains into the left subclavian vein. Okay, and then of course it's into the systemic circulation. Okay, so nutrient absorption we spoke about, so excretion of waste. So once the small intestine has done the majority of the absorption of nutrients, the waste is delivered to the colon, right? And the colon does a couple of functions. The waste that's delivered is very liquidy, and the body doesn't want to lose all this fluid. So the colon does some reabsorption of water. Okay, so the colon's important for that. It does a bit of absorption of electrolytes. It stores stool, right? So we need to store stool, otherwise, well, we'd be incontinent all the time because we're not able to hold this or store the stool anywhere. And also excretion of stool, right? So think of the colon as water reabsorption, a bit of electrolyte reabsorption, storage of stool, and elimination of stool. Okay, so these two images are just the zoomed images of the previous slide. Just as I always try to get a big picture of things before zooming in and looking at a smaller picture of things. It just helps with understanding. Okay, so we have the esophagus coming down that attaches to the stomach at the gastroesophageal junction, the GE junction. Okay, the stomach is going to churn, so it's going to contract. It's going to churn the food, so there's mechanical digestion of food. There's also some chemical digestion of food in the stomach, right? It has a pH of around 2 to 5, so it can start the digestive process. It also secretes an enzyme called trypsinogen, which is converted to trypsin, which is an enzyme that can start the process of protein breakdown, right? And then this material, which is called chyme, is delivered to the first part of the small intestine called the duodenum. Okay? At the duodenum, you have Kupffer cells that are able to secrete an alkaline solution to raise the pH of the liquid that's coming from the stomach. Otherwise, it's going to burn the small intestine because the pH from the stomach is so low. It's very acidic, okay? So you have the duodenum, which is a relatively short segment of the small intestine. It's where the common bile duct is going to insert to allow bile to come into the small intestine. And it's also where the pancreas can secrete pancreatic juices into the small intestine. Okay, and then you have the jejunum, which is the middle segment, which is heavily involved in digestion and absorption of nutrients. And the third segment is the ileum. Okay, and remember, the ileum, the distal ileum, is prone to a few diseases. So the first one, one main disease, and the one that you should remember for the distal ileum is Crohn's disease. Okay, so that's an inflammatory condition, and people can often present with right lower quadrant pain because that's where the distal ileum connects to the large intestine, the colon. Okay, so they can present and kind of mimic appendicitis because that's where the appendix is as well. So when you have distal ileum disease from Crohn's disease, you're unable to absorb vitamin B12, and you can develop megaloblastic anemia from Crohn's disease causing distal ileum disease. Okay. What else can happen? Well, this area is also where bile gets reabsorbed. So remember, bile is secreted in the duodenum, but the body kind of wants most of it back. So it reabsorbs a lot of the bile in the ileum, right? So if there's disease there, you don't tend to absorb your bile, and it goes into the colon, and bile in the colon tends to cause diarrhea, okay, because it's irritating to the colon. Okay, so you can have malabsorption of bile, you can have malabsorption of vitamin B12 in the distal ileum. Okay, so let's look at the image on the right. I'm not going to start right at the beginning, the mouth again. I'm going to go down and just mention a couple of things that I didn't mention before. So just notice where the spleen lives. Okay, the spleen lives tucked under your left lower ribs. Okay, so they're a bit protected by the ribs, and they're to the left. It's to the left of the stomach. Okay, and that's why it's prone to an injury that occurs at the left lower chest, right? Because the spleen is basically a small bag of blood. Okay, I mean, just basically, it's just filled with blood. It's part of the immune system, and it's a really important organ of the immune system, and we know that because when patients lose their spleen, say from trauma or disease, they are immunosuppressed. Okay, so know where the spleen is, and just know that if you don't have your spleen, you are at risk for serious infections, and we typically give those people immunizations to protect them from a lot of invasive diseases. Okay. Notice where the liver is. It basically takes up the whole right upper quadrant under the diaphragm there, right? And you can see the gallbladder in this image just under the liver, and the gallbladder will drain into the common bile duct, right? So you have bile that's coming down, that's produced in the liver, and some of it is stored in the gallbladder, and some of it continues down the common bile duct, and it can be secreted into the duodenum. Okay, you can't really see the pancreas here. Maybe a tiny little segment. It's tucked behind the transverse colon, but the pancreas almost looks like a long fish fillet. Okay, so it's tucked behind the transverse colon, and it often extends almost all the way to the spleen. It's a good size. It's bigger than most people think. Okay. There's a pancreatic duct that collects the digestive juices that are produced in the pancreas and secrete them into the duodenum. Okay. I won't mention the jejunum and the ileum again, but notice that the ileum, which is the last part of the small intestine in the right lower quadrant there, drains into the cecum, which is the first part of the large intestine. And notice where the appendix is. And that's why often we confuse appendicitis with the initial onset of Crohn's disease. Okay, they can be very confusing until we do imaging tests. Okay, and then we have the ascending colon, the transverse colon, the descending colon, the sigmoid colon, and then the rectum, and then followed by the anus. Okay. Okay, so when we're seeing a patient with abdominal pain, the most the most useful part of the entire um, examination is the history, because if we obtain a good history, there's a very good chance we're going to be able to narrow down the possibilities. Okay, and on the next slide, I'll show you what I mean by that. Okay, so when someone comes in with abdominal pain, we want to know all about the abdominal pain. So where is it? So what's the location? What does it feel like? Is it sharp? Is it dull? Is it constant? Is it intermittent? Everything about the pain. Okay? Does it radiate to the back? Does it radiate to a shoulder? Did it start suddenly? A pain that starts suddenly is usually something that's either become blocked, such as a kidney stone or a gallstone, or something that's twisted, such as the bowel, right? Sudden onset of a pain. Or something that's ruptured, like an aneurysm. Okay, so the pain and the history of the pain is really, really important. If I hear that someone's had pain for 5 years, I'm probably not as concerned as if someone said, I've had severe pain that started suddenly 1 hour ago. Okay, so anyway, so the pain history is very important. Do they have dyspepsia? So dyspepsia is just a kind of an umbrella term for upset stomach. Okay, that's all it means. So you could ask, do you have dyspepsia? Or most people may not know that. Do you have an upset stomach? Are you nauseated? Okay, gas and bloating. So just some patients will just provide this information that they're burping a lot, or they're passing a lot of gas and they're bloated. Okay, bloating can sometimes be an indication of a bowel obstruction if they're really bloated, but most of the time it's just an upset stomach or dyspepsia. Are they vomiting? And if they are vomiting, how much? How frequently? Are you vomiting once a day or 20 times a day? Okay. Blood. Have you noticed any blood in your stools, or have you vomited any blood? Personal history. Do you have a past medical history of anything uh, to do with your abdomen? Do you have ulcerative colitis? Do you have Crohn's disease? Um, what's your what's your surgical history? Do you still have your gallbladder? Do you still have your appendix? Okay, so anything to do with past medical history of their abdomen. Some people will say, well, I get this pain every month. Okay, well, that's going to help. You get this every month. Okay, so now I can think of things that occur every month. Or I've had this pain 10 times in the past year. Or I never get this pain. Okay, so the personal history of the patient. Okay, change in bowel habits. When was your last bowel movement? Was it normal? Was it hard? Was it diarrhea? Was there blood with it? Okay. Change in diet. Okay. Are you hungry? When's the last time you've eaten? Has your diet changed at all? Are you traveling and that's why your diet's changed? Okay. Medication history. Have you started any new medications? Have you been on antibiotics recently? Okay. Do you take NSAIDs or aspirin every day? So all of those things that might lead us to um, a clear understanding of where the pain is coming from. Family history would be linked more to genetic conditions, right? Irritable bowel, inflammatory bowel diseases such as Crohn's or ulcerative colitis, gallstones. I'm going to tell you, in the moment when someone's having pain, family history is not that useful because they're here in the moment with the pain, and family history is just really a risk factor for conditions. Laxative use. So are you someone who has to take a laxative every day, or okay, because that can affect the bowel, right? On the right, I left this slide. I think it's a bit useful. So foods and medications that can alter the stool. So meat, it can make the stool dark brown. Why? You get more bile secreted, right? So in order to digest the fat that's in many meats, you secrete more bile, and bile is what gives your stool that dark brown appearance. Spinach can turn your stools green. The one that really turns your stools red is beets. Okay, that one is notorious for turning your stools red. Cocoa, okay, dark brown, that kind of makes sense. Cocoa. I'll skip senna. So senna-cot is a laxative. I don't have much to say about that one. So what turns your stools black? So bismuth, so Pepto-Bismol, turns your stools black. We always ask patients when they come in with black stools, because we want to know if they're taking bismuth in Pepto-Bismol, and that's why their stools are black, right? Iron, so iron supplements turn stools black, and patients come in if they weren't told, and they're concerned about black stools. The most important cause of black stools is blood, and it's not listed here, probably because it's not a food or a medication, but blood is the one that we're really looking for. Okay. Black licorice can turn your stools black, and charcoal, we usually know if someone's taken charcoal because we've probably given it to them for a drug overdose. Okay, so any of these can turn your stools black, but don't forget the one that we really care about is bleeding. And if you have black stools from blood, the bleeding is coming from the upper gastrointestinal system, so the esophagus, the stomach, or the duodenum. Okay, what can turn your stools white? Well, barium, usually we would know that because they would tell us that they just had a barium test. Okay, what else turns your stools pale? Well, some kind of obstruction in the biliary system. Okay, so if you have a stone that's blocking your common bile duct and your bile can't get to the small intestine, well, your stools are going to become pale because the bile is what gives your stools their brown color. Okay, so any obstruction of the biliary system will cause pale stools. Okay, so this slide is not meant to scare you at all, and if you know where organs are in the abdomen, then it'll make sense, right? So if we look in the right upper quadrant, so the red disease is there. So right upper quadrant, well, what's in the right upper quadrant? The liver, so there's hepatitis, or liver abscess, which is an infection within the liver. Cholangitis is a blocked common bile duct causing infection. Gallstones, okay. Remember that the heart can always give you upper abdominal pain. Okay, so that's why we get an ECG on anyone who has upper abdominal pain. And the other thing to know is the lungs come down lower than you might think. Okay, so the diaphragms are like domes, and the lungs come down further in someone's chest than you might imagine. So lung causes can give you upper abdominal pain. Okay, because that's how far the lung comes down. Okay, if you look at the epigastrium, well, just think what's in the epigastrium. Well, the esophagus is coming down into the stomach. The stomach is partially there, and the duodenum is there, so ulcers. The pancreatitis is totally in the epigastrium. Okay. On the left side, left upper, well, the stomach's there, but the spleen is there. So someone who comes in with left upper quadrant pain, we're thinking of splenic issues, stomach issues, okay? And I won't cover all of these, but just take a look at them. Well, let's go to the lower for a minute. Left lower quadrant, diverticulitis, okay? So most diverticulum that we develop, which are little outpouchings of the bowel, are in the left colon. So it makes sense that most of the diverticulum that are going to become infected and cause diverticulitis will be on the left side. And the vast majority of them are in the sigmoid, the descending colon and the sigmoid colon. So where do you get the pain of diverticulitis? Left lower quadrant. Constipation can give you pain in the left lower side because that's where the rectum is and the sigmoid colon. Ovarian cysts can give you left or right lower pain because there's two ovaries. Hernias, so inguinal hernias that are strangulated will give you pain in your groin, left or right. Okay. Right side, appendix, Crohn's disease. We always have to think of ectopic pregnancy on either side. So an ectopic pregnancy is a tubal pregnancy, a pregnancy that's typically occurring in the fallopian tube, and it can rupture and there can be massive hemorrhage. That can be right lower abdominal pain or left lower abdominal pain. Look at the center. So the lower central abdomen. Well, cystitis, bladder infection, that's exactly where the bladder is. Urinary retention, so you're unable to empty your bladder, so you're uncomfortable in the lower abdomen. Someone who comes in with a twisted testicle often complains of not only scrotal pain, but lower abdominal pain. Okay, so if you know where the organs are, you'll have a good idea of where the symptoms will be for that particular organ. Okay. Okay, so let's look at some blood tests for different parts of, different abdominal diseases. So let's look at liver function tests. So liver function tests, you typically get an AST, an ALT, an ALK Phos, and a bilirubin. Okay, and sometimes, and we can ask for ammonia as well. Sometimes we'll get an ammonia. Okay, so AST and ALT are enzymes that are typically within hepatocytes. So anything that destroys the hepatocyte, the liver cell, releases AST and ALT into the bloodstream. Okay. Alkaline phosphatase also is an enzyme that is released into the bloodstream with liver injury, or it's very useful in obstruction of the common bile duct. So alkaline phosphatase tends to be much more elevated when there's blockage of the bile duct. Okay, so we rely on that and we look at it for obstruction of the bile duct. Bilirubin, again, so bilirubin is a breakdown product of red blood cells. So red blood cells are destroyed in the spleen. They are converted. So the heme group of the hemoglobin is converted to bilirubin, and bilirubin is normally secreted into the biliary system, right? So anything that injures the liver, such as hepatitis, cirrhosis, will cause an elevation of bilirubin in the bloodstream because the liver isn't processing and excreting the bilirubin normally. Okay. What else can elevate bilirubin? So I mentioned the fact that the liver, whether it's hepatitis or cirrhosis, or even blockage of the common bile duct, will cause bilirubin to back up and spill into the bloodstream. Okay. What about just breakdown of red blood cells in the bloodstream? So there's conditions where the red blood cells break down, such as sepsis or DIC, okay, which is disseminated intravascular coagulation, and red blood cells break down. And when red blood cells break down, you get tremendous amounts of heme released into the bloodstream, and that gets converted to hemoglobin, that gets converted to bilirubin, and you have an elevated bilirubin. Okay, so it's hemolysis of red blood cells, and typically liver diseases. Okay, such as cirrhosis or hepatitis or obstruction of the common bile duct. Ammonia. What causes elevation of ammonia? Well, ammonia is typically processed in the liver, right? So ammonia comes from amino acid metabolism, and it's a toxic chemical, right? So the body converts ammonia to urea, and urea is excreted as blood urea nitrogen in the urine, right? It's a non-toxic substance. So if the liver is injured or diseased, you can't convert ammonia to urea, and you get elevations of ammonia in the bloodstream, which makes people sick. They get hepatic encephalopathy. So ammonia is so toxic that it affects the brain and causes confusion, decreased level of consciousness. So we typically have to treat patients and lower their ammonia levels when they come in with hepatic encephalopathy. Okay, so let's look at some other ones. Amylase and lipase. Okay, those are typically elevated in pancreatitis. Okay, those are enzymes produced in the pancreas. So when the pancreas is inflamed and releasing its enzymes into the bloodstream, amylase and lipase are elevated. Lipase is much more sensitive to pancreatitis than amylase. Why is that? Well, amylase is made in other parts of the body, such as your mouth, the saliva. So conditions of the mouth and the salivary glands can put up the amylase, whereas lipase is really much more specific to the pancreas. Okay. CBC can be useful in terms of the white blood cell count. If it's elevated, it could make us think of inflammation or infection. We'll look at the hemoglobin to see if someone's anemic, say from bleeding. Complete metabolic panel, electrolytes, right? Creatinine, BUN. PT-PTT useful because if your liver is failing, your clotting factors are not going to be produced. You're going to have an elevated PTT, and INR. Okay. CEA is really just reserved for patients with cancers. It's elevated in certain colon cancers. So we don't usually order it as an initial test, but patients that have colorectal cancer, their CEA levels may be followed to see if they're descending, which means that the treatment is showing some success. Okay. And lastly, don't forget about albumin, right? Albumin is a large plasma protein. It's actually the most common plasma protein in the body. It's made in the liver. It provides your oncotic pressure. And if you have significant liver disease, your serum albumin will likely be low because the liver is not producing enough of it. Okay, so this next slide I'm going to spend next to no time on because we really don't do 24-hour urine collection for bilirubin or urobilinogen. Okay, so the one test that we really do 24-hour urine tests on is protein. And why do we do that? Well, sometimes we'll do it with someone who we think has nephrotic syndrome, and we're looking for excessive 24-hour protein loss in the urine. Sometimes we'll do it in a diabetic who's losing a lot of protein because diabetics develop proteinuria. That's part of the kidney disease that they develop, and they start to spill protein into their urine. So sometimes we want to know exactly how much they're spilling. We don't typically do a 24-hour bilirubin test. So if we notice on the dipstick, which gives us a really fast um, idea of what's in the urine, and you can see it in the lower left images there. If we see that someone has urobilinogen on their dipstick, then we'll just do a serum bilirubin. That's the quickest way, okay? The 24-hour collection, I know it's mentioned in ATI. I'm not going to cover it, but what's causing someone to have an elevated bilirubin is going to be the same causes that cause them to have bilirubin or urobilinogen in their urine. It's the same. So I already mentioned that. Cirrhosis, hepatitis, obstruction of the bile duct, which is causing bilirubin to back up into the bloodstream, or hemolysis, or what's called hemolytic anemia, where the red blood cells are rapidly breaking down in the blood and releasing their heme groups, which turns into bilirubin, causing jaundice. Okay, so that's all I'm going to say on this, and we'll move on to the next slide. Okay, so let's look at some stool tests. Okay, and the first one is fecal occult blood testing. Okay, so we'll acquire a sample of stool, and there's these little cards that patients get, or that we could use in the hospital. And we acquire some stool, we put it on one side of the card, we close the card, and we turn it over and put the solution on it. And if it turns blue, then we know there's blood there. Okay, so that's what fecal occult blood testing was for. That we can't necessarily see the blood in the stool when we examine it, but there is microscopic blood in there that's picked up with fecal occult blood testing. Okay. Now, does it tell us where the blood is coming from? Absolutely not. Okay, it could come from a bit of blood that's trickling from a stomach ulcer. It could come from a lesion in the colon. It could be blood even from a hemorrhoid that's now in the stool and on the sampler. Okay, so it doesn't help us with the location. It just tells us, yes, there's some microscopic blood when we test it. Okay, so what do we have patients typically do? Well, we ask them before doing the fecal occult blood test, which is a screening test, by the way, for colon cancer, typically between the ages of 45 to 50. Don't have any NSAIDs, don't take any NSAIDs or anticoagulants days prior to doing this test, because it might make you bleed a bit and it'll give us a false positive test. What else should they avoid? Well, typically they should avoid anything that can also give false positive tests. So I mentioned NSAIDs or anticoagulants. I mentioned a couple of days. Typically it's 5 to 7 days we actually ask them to hold those medications. They need to check with their doctor though, or their healthcare provider about holding their anticoagulant for 7 days. That can be an issue, right? What else should they avoid taking? Well, vitamin C, so foods that are very high in vitamin C. Red meat can give you a false positive fecal occult blood test. Chicken, fish, things like that, they have to hold prior to taking this test. Okay, so medications such as NSAIDs and anticoagulants, and those foods and vitamin C that I mentioned. Okay. So in terms of the fecal occult blood test, just remember, it does not tell you the location of the bleeding. It just tells you it's picking up some microscopic blood. Okay, so as a screening test at the age of 45 to 50, if you have a positive fecal blood test, and typically you do 3 of them, okay, so when you do 3 of them, it increases the sensitivity of the test. And then if it's positive, the patient can be offered a colonoscopy, okay, looking for any sites of bleeding, and in particular colon cancer. Some centers in North America, in Canada, United States, we don't really rely on a fecal occult blood test at the age of 45 or 50. We just go directly to a colonoscopy. Because what if you aren't bleeding that day? What if this cancer didn't bleed on the day that you collected the stool samples? Well, they'll be negative. And so we don't totally rely on them. Compared to a colonoscopy, which is super accurate. It's going to tell us definitively, yes, there's a colon cancer, or there's something that's bleeding in your bowel, or no, there isn't. So much more sensitive and specific test. Okay. Next one, ova and parasites. So ova and parasites are from infection, right? So parasitic diseases, and typically they cause diarrhea. Okay. And often there's a travel history outside of the United States, okay? Because other countries, especially third world countries, they're more prone to having parasitic infections. So what kind of parasitic infections do we look for typically in the United States and Canada? Well, Giardia is a parasitic infection that gives us abdominal pain, diarrhea, loss of appetite, and another one called Entamoeba histolytica, typically obtained through contaminated food or dirty water, right? So you went camping, you drank out of a pond or a river system, and it had Giardia in it. Giardia typically comes from beavers, and now you have an intestinal parasite. Okay, so the ova and parasite testing will pick up Giardia and Entamoeba. Okay. By the way, we can also do, so not only do we get stools for ova and parasites when we're looking for infections, we also get stools for CNS, culture and sensitivity, right? Because we're looking for bacterial infections such as Salmonella, Shigella, Campylobacter, E. coli, right? So we're also looking for those. So typically it's a CNS and an O&P if someone has ongoing diarrhea. We can test for C. diff toxin. So not the actual bacteria, but the toxin that the bacteria is producing. So we send off the diarrhea, and very quickly, typically within 24 hours, we'll get a result whether there's C. diff toxin present. And these patients typically have a history of taking antibiotics. They have abdominal pain. They have profuse diarrhea, sometimes bloody. They can have distension of their abdomen because these bacteria, the Clostridium bacteria, produce tremendous amounts of gas. And they have foul-smelling stool. Okay, the whole department can typically smell the diarrhea of Clostridium difficile. Okay, how do we treat it? Vancomycin orally, or metronidazole orally. But first line right now is vancomycin. Okay. Okay, so let's talk about endoscopies. And endoscopy is a general term for basically a scope, right? So it's to visualize the upper intestinal area or the lower intestinal area. So an upper endoscopy is we typically, to shorten the term here, a gastroscopy, right? A lower endoscopy is a colonoscopy, or if we just want a view of the sigmoid, we'll call it a sigmoidoscopy. It's just a shorter tube with a camera and a light on it, right? So upper endoscopy, if you want the long term, it's esophageal gastroduodenoscopy. We typically call it an upper GI scope or a gastroscopy. Okay. So what can we do with a upper GI scope or a lower GI scope, a colonoscopy? Well, let's look at the upper GI scope first. So we can diagnose anything in the esophagus. So if someone has esophagitis, esophageal varices, anything that's bleeding in the esophagus, the scope with the camera looks into the stomach, looking for gastric ulcers, gastric cancers, gastritis, which is inflammation of the stomach, and it can go as far as the first part of the duodenum, so it can diagnose duodenal ulcers as well. At the same time, an upper GI scope can treat these conditions. So for example, if there's something bleeding, it can be used to cauterize, right? So at the same time as viewing, there's another part of the scope that they can manipulate and cauterize bleeding lesions, or they can take tissue samples of the esophagus or the stomach to diagnose inflammation, cancer. They can even take a biopsy and see if there's H. pylori, the bacteria that causes gastric and duodenal ulcers. Okay. Colonoscopy, well, we'll talk about that in more detail. That requires a more significant scope. Typically an upper GI scope just requires the patient to be NPO for 6 to 8 hours, so their stomach is empty, they go in and have the scope. Colonoscopy needs the colon to be completely clear of stool, right? So there's a purging process that takes place, a preparation that typically starts the day before and the day of the colonoscopy, so that the colon wall is completely clear of stool, so they get a full visualization of the colon. So a colonoscopy really looks at everything from the anus all the way to the cecum on the other side. Okay, let's look at this next one, endoscopic retrograde cholangiopancreatography. So again, this requires an upper GI scope. So they put the scope down, and there's a camera on it, and they go into the esophagus, into the stomach, and then into the first part of the duodenum, and they isolate the little valve, or what's called the ampulla of Vater, or the sphincter of Oddi, where the bile comes out. They can put the probe into there and then put dye into the biliary system. And then they take images. So what does that do? It gives a full picture of the biliary tree and the pancreatic duct, because it's been filled with dye and they've taken images. So that allows for diagnosis of a blocked biliary system, such as from a gallstone. It allows images of the pancreatic duct to see if there's any blockage, say from a pancreatic cancer. So again, a very useful test to look at the whole biliary system and the pancreatic duct. Okay. We'll talk about another one called M2A, which is a pill cam, and basically you swallow this little capsule, which I think is amazing, with a glass of water, and there's a video, there's a little camera attached to it, and it traverses from the stomach all through the small intestine until it gets to the colon and then out. So why is this done? Well, you can't really put a camera or a scope into the small intestine. It's too small, it's too long. So the small intestine is an area that's hard to visualize with a camera. And so this capsule was invented in order to take images of the small intestine. It's not used for the colon, okay? And it's not required for the stomach either. It's really for the small intestine, okay? So if you're wondering, so basically as this capsule is going through the small intestine, they're getting images on a data recorder. And then you wait for the pill to be excreted with the stool, and the camera is obtained again, right? Because you don't want to lose that little capsule camera. Okay, so let's go on and talk about each of these in a bit more detail. So just remember, colonoscopy for viewing the colon, right? From the anus all the way to the cecum. A esophageal-gastroduodenoscopy, that term is way too long. So an upper GI scope or a gastroscopy. Those terms are also used. That's reviewing the esophagus, the stomach, and the first part of the duodenum. ERCP, again, a scope that goes in, and it has the ability to provide dye. So the scope goes to the sphincter of Oddi and squirts dye into the pancreatic system and the biliary system to have a full view of those two areas. And finally, the pill cam that can view the small intestine if needed. Okay, so let's start at the lower end. So a colonoscopy. So this allows for direct visualization of the anus, so they can see hemorrhoids, and then into the rectum, right? Because you can get rectal carcinomas, you can get sigmoid cancers, you can get diverticulosis in the sigmoid, or the descending colon. But the scope will go and look at the entire lumen of the colon all the way to the cecum. Okay, most people need some form of sedation, okay, and some pain control. It can be uncomfortable for some people. So a benzodiazepine such as midazolam plus an opioid such as fentanyl for pain control can be given. Okay, so a bit of midazolam and a bit of fentanyl. You're not necessarily completely unconscious for this procedure. Some people are, because they prefer to be, but some people just require some sedation and some fentanyl for pain control. Another medication that can be used for sedation instead of midazolam is propofol, just another sedative. Remember, neither of these have pain relieving properties. They're just sedatives. The pain relieving property comes from an opioid, such as fentanyl. Okay? The patient is usually put on their left side with their knees flexed towards their chest. Okay? And the scope is inserted. Okay, so what is the preparation for this? Remember, the entire colon has to be clear of stool. So the bowel prep typically involves something called polyethylene glycol, which is a liquid, and one of the brand names for it is Go Lightly. And it usually comes in a 4-liter jug. Okay, and it doesn't taste good. It's got a kind of a soapy taste to it. So often it's recommended to put it in the fridge because that helps with drinking it. And not only do you need the 4 liters of the polyethylene glycol, which basically just purges you of all intestinal contents, including all stool, but also you take a stimulant laxative, such as bisacodyl. Okay? Remember, when you're taking polyethylene glycol, 4 liters of it, plus bisacodyl, this is definitely going to impede absorption of any medications that the patient is taking. Okay, so the day before the procedure, you switch over to a clear fluid diet, typically in the afternoon. Okay, so clear fluids are things that you can see through, right? For the most part. Now, it's also recommended that you don't have any colored fluids when you're on a clear fluid diet for this procedure, such as some kind of red juice or orange flavored juices. Anything that can cause the colon to stain a bit with the coloring will make it harder to see lesions during the colonoscopy. Okay, so for example, I had someone who ate a lot of Jello as a clear fluid, but the Jello was red. Okay, and so now they came into the hospital because after starting the polyethylene glycol, they had red stools and they'd forgotten about the red Jello. So that's not going to help with the colonoscopy if they have red staining of their colon because they drank something that was red. Okay, so avoiding colored fluids. So once you've purged yourself, that that day because you started the Go Lightly and you're completely purged after 4 liters of Go Lightly or polyethylene glycol, you're then NPO after midnight. Okay, so there's nothing to consume after midnight prior to the day of procedure. Now, some medications also need to be avoided prior to a colonoscopy because there's a risk of bleeding, especially if they take a sample of a polyp, or say they touch the colon wall by accident and it starts to bleed. So antiplatelet medications such as ibuprofen, aspirin, anticoagulants such as warfarin, non-steroidal anti-inflammatories, I mentioned ibuprofen, they put the patient at higher risk for bleeding. So these are often restricted prior to the colonoscopy, and the patient is given that advice. So for this procedure, and basically any other procedure, the patient needs to sign a consent form. There'll be vital signs taken. Typically they have baseline blood work, such as a CBC, electrolytes, kidney function, clotting status, so a PT and PTT. Sometimes we'll do a chest x-ray and an ECG, especially if the person is older. Okay. Now, older patients, so we mentioned medications that should be avoided prior to a colonoscopy. Anyone who's had a study that involves barium prior to a colonoscopy needs to wait, because barium stains, it's a chalky material, so it's going to make visualization of the colon wall very difficult. Okay, so if you've had a barium study before a colonoscopy, we have to wait for all the barium to get out of your bowel, okay, to properly view the colon. Older people can have a very difficult time taking the polyethylene glycol. It's 4 liters. It can cause some electrolyte shifts in older patients. I mean, this is difficult for a young person to do, to consume 4 liters of this, right? And then after the polyethylene glycol plus the bisacodyl laxative, they're NPO after midnight. So it can be a difficult process for an older patient, right? Now, after the colonoscopy, which typically takes anywhere from, well, it just depends if they have to do biopsies and if they have a difficult time viewing the entire colon, but it typically takes anywhere from half an hour to an hour. So there's a post-procedure assessment and observation, right? So typically patients will stay in a recovery room for a period of time until the sedation and the opioids have worn off. So they're going to need to have their vitals monitored. They're going to be they'll be monitored for complications. So someone who's just had a colonoscopy and has severe abdominal pain, well, that may indicate the small risk of a perforation where the scope went through the colon wall and has now caused peritonitis, right? It's a very low risk. I think it's about 1 in 1,000 across most centers, so it's pretty low, but it can happen, right? So bleeding is a complication, and perforation is a complication. So monitoring that with abdominal pain, fevers, and in terms of bleeding, monitoring for any rectal bleeding, right? The vital signs and respiratory status are important, especially since they had an opioid plus either a benzodiazepine or propofol. Okay, so you have to monitor the airway, make sure that they have a good O2 saturation and that they're breathing comfortably. Okay, after the colonoscopy, they can resume their normal diet. They can go right back to their normal diet, and also to increase fluid intake because they've been NPO since the night before. Okay. Now, the patient may also notice that they have more gas. because sometimes with colonoscopy, in order to get a really good view, they have to pressurize, they have to blow some air into the colon to kind of open up the lumen of the colon. So after the procedure, the patient may notice that, yeah, I have a lot of gas, and it's because of all the gas that was put into the colon by the healthcare professional. Okay, and typically you need someone to drive you home. You can't go home after receiving IV midazolam and IV opioid, so you need a driver. And usually you're advised not to drive for the rest of that day. Okay, so let's talk about the upper scope. So an esophageal gastroduodenoscopy, or we tend to shorten that and call it a gastroscope, or an upper GI scope. And this allows us to directly visualize the esophagus, the stomach, and the first part of the duodenum. And what are we looking for? Well, just depends on the symptoms that the person has. So if someone has esophageal symptoms such as heartburn or difficulty swallowing, or food is sticking in their esophagus, we're going to put a scope in and look and visualize the esophagus, whether it's for ulcerations, esophageal varices, cancer, anything like that. So again, we can also look into the stomach for cancers, gastric ulcers, gastritis, and these patients typically have abdominal pain, or rectal bleeding, such as melena in the case of a gastric ulcer. A duodenum, we can see the first part of the duodenum, and we're looking for duodenal ulcers. Remember, gastric ulcers are prone to have cancer within them. So even after we diagnose a gastric cancer and treat it, they need a repeat scope months later to make sure it's completely healed, because gastric cancers can have cancer within them, and that's why they get biopsied. Duodenal ulcers don't tend to have cancer within them at all. Okay, so those are the things that we can diagnose with an EGD. Also, it can provide therapeutics. So lesions can be cauterized with a upper GI scope. So say esophageal varices or a bleeding stomach ulcer. We can take tissue biopsies of an ulcer. We can take a tissue biopsy and try and grow H. pylori in the case of a peptic ulcer. A peptic ulcer is referring to either a gastric ulcer or a duodenal ulcer. It's just an umbrella term. Okay, so let's look at the preparation. It's basically NPO for about 8 hours, and that's it. So just don't eat or drink for 8 hours, and then you can have an EGD. There's typically anesthetic involved. So just to moderately sedate. So midazolam or propofol are sedatives. Fentanyl is not a sedative, it's an opioid. It's for pain control. Okay, so often people get midazolam and fentanyl, or propofol and fentanyl. Other medications. Well, we often spray the back of the throat with a topical anesthetic such as lidocaine to suppress the gag reflex as the scope goes into the mouth. Okay, most of us would really gag as this scope is going to the back of our throat, so this can be suppressed with a topical anesthetic. Atropine can also be used to dry up the secretions in the mouth. So say someone has a lot of saliva and they're gagging, well, that can be dried up with atropine. Okay. So so the positioning of the patient, they are typically lying on their left side with the head of the bed elevated, right? And they can easily access the mouth that way. Afterwards, so after the, so not only do they have to be NPO prior to the procedure, but dentures should be removed prior to the procedures, because they can be loosened, as the scope is going across the teeth. So the dentures are just taken out for ease. Okay. Post-procedure, well, they've had some medications. They've had midazolam and fentanyl, likely, and they need their vital signs and definitely respiratory status monitored, okay? And to make sure that they constantly have an open airway. So for example, if their neck is flexed and their head is dangling because they're so sedated, well, you want to make sure that their head and neck is in a good position so that their airway is open, okay? Monitoring for bleeding, right? So where would you see bleeding potentially? Well, someone could vomit up some blood after an EGD because they had a biopsy, okay? Or they may present with melena later on because they have bleeding following a biopsy of a lesion. They may complain of chest pain, which is typically esophagus, or abdominal pain post-procedure, okay? Definitely withholding any medication until the patient is awake, alert, and they have a return of their gag reflex. And once they do, they can start oral fluids, and the IV fluids are no longer needed. Okay? Again, just like a colonoscopy, the patient is advised not to drive that day because they've received IV sedatives and opioids. And in order to go home, you need a driver. You can't go to a colonoscopy or an upper gastroscopy without a driver. They won't let you go home. It's not safe, right? If their throat is sore, sure, they can sip fluids. Afterwards, they can take lozenges because sometimes the throat is irritated after having had a scope go across it. So what are the complications of an EGD? Well, if the person's not sedated enough, they could vomit. That wouldn't be good because then they could aspirate. The scope could potentially perforate the esophagus or the stomach or the duodenum. They could get significant bleeding from a biopsy during the procedure. Now, if there is perforation of the stomach or the duodenum, that would go into the peritoneum, so they can get peritonitis. These are rare complications, but they can definitely happen, and the patient would be advised on these potential complications, but they're very unlikely. Okay, so here's an ERCP, so an endoscopic retrograde cholangiopancreatography, okay, ERCP, and it's a scope that starts in the mouth, traverses the esophagus and stomach into the duodenum, and at the sphincter of Oddi, it can spray dye into the biliary system, so the biliary ducts, and the pancreatic system. Okay, so the ducts of the pancreas. It's actually not showing in this image that the contrast media not only goes into the common bile duct, it goes into the pancreatic duct as well. Okay, note the shape of the pancreas. It really reminds me of a fillet of fish, and maybe that's why I don't like eating fish now. And it almost, the tip of the pancreas, the tail we call it, almost touches the spleen. It's quite long. Okay. All right, so what does it allow? Well, it allows us to directly visualize the biliary ducts, the gallbladder, the liver, and the pancreatic ducts. Okay, so the patient is going to lie on their left side with the head of the bed elevated. Again, they're going to need sedation in the form of midazolam or propofol, plus a pain medication such as IV fentanyl. The same things would apply to suppress the gag reflex in terms of topical lidocaine and atropine, which is an anticholinergic agent to dry up secretions orally. Okay, in terms of post-procedure, I'm not going to go through it again because it's very similar in terms of monitoring vital signs, monitoring that the airway is open, increasing fluid intake after they've woken up and they have a gag reflex, right? Discontinuation of the IV fluids once they're drinking well. They can resume their diet once they've had their gag reflex return and they're fully awake. Okay. And again, they're advised not to drive for that day, right? And they need a driver to take them home. They can take lozenges just like in an EGD. One of the complications of this that's not mentioned here, and I don't see it in the book, but it's kind of an important one, is that the contrast media that's put into the common bile duct can really irritate the pancreas. And this can be a cause of pancreatitis. Okay, so the pancreas reacts with this contrast media and it becomes incredibly inflamed. So the patient's going to be advised that there's a small risk of developing pancreatitis from this procedure, on top of all the other complications that we mentioned for an EGD, such as perforation, bleeding, the potential for aspiration because they've been sedated and they might vomit. Okay. Okay, so the pill cam, remember the pill cam is really to have a good look at the small intestine, which is a really hard part of the bowel to visualize. So the colon is pretty easy to visualize. The esophagus and the stomach and the first part of the duodenum is easy. Small intestine, really difficult. So this is where the pill cam comes in, okay? And it's looking for any disease process in the small intestine, whether we're looking for bleeding or inflammatory bowel disease such as Crohn's disease, or sometimes even celiac disease, which is a small intestine disease, right? So we're just getting direct visualization of the small intestine wall. No anesthesia is needed, no positioning is required, and typically all that's needed is to fast 8 to 10 hours before the procedure, because you don't want the pill to be mixed with food. So you want all the food to get way down the gastrointestinal system, and then you take the pill. Okay. After you've taken the pill, you're NPO for about 2 hours. Okay. Then typically you can start with clear fluids, and after 4 hours you can start with food. And the pill cam is far enough ahead that the food's not going to catch up with it and cause poor visualization of the small intestine. Okay, so the abdomen is marked with sensors and it's connected to a recorder, and that provides good images of the small intestine. Okay, so after so what's the post-procedure care? So that little camera is going to come out in the stool. The patient is going to return the camera, of course, back to the department where they got it from. Okay, so let's look at some endoscopic complications. So whether we're talking about a colonoscopy or an esophageal-gastro-duodenoscopy, we could oversedate someone with the medications. So here comes that midazolam or propofol plus fentanyl. So oversedation, that becomes an airway issue, and that's why it's so important to monitor the airway and the vital signs, including the O2 saturation of someone after a procedure. Okay, because of that decreased respiratory drive from the sedatives and the opioids. Okay. They could be tachycardic. Well, why could they be tachycardic? Well, what if they're bleeding? So one of the first signs of bleeding that we may not see yet in the stomach, in the duodenum, or after a colonoscopy would be tachycardia. So sinus tachycardia can be one of the first signs that something bad is happening inside, and it could be internal bleeding that we just haven't seen yet. Okay, so we monitor for tachycardia. So if someone has a heart rate of 120 after this procedure, we're going to be concerned that something is happening that's caused some bleeding inside their gastrointestinal system. Decreased blood pressure, again, the same thing, bleeding. We'd be concerned about bleeding if they were hypotensive. Most people aren't typically hypertensive. They don't typically have high blood pressure after the procedure. So we would be more concerned about tachycardia and low blood pressure because that could signify bleeding internally. And we come to the next subject, the next complication, hemorrhage. So bleeding can occur because of biopsies taken, right? Or the scope was done for bleeding in the first place, and maybe the scope just irritated the area following a biopsy, and now it's bleeding it even more. And that's why patients need to hold their antiplatelet medications, not take NSAIDs, and hold their anticoagulants prior to this procedure. Okay. Now, if you're hemorrhaging, again, I mentioned this, you'd be hypotensive, low blood pressure. You'd be tachycardic. You might look a bit pale. You might look a bit sweaty, so clammy. Why? Sympathetic nervous system is turning on, right? Because of the bleeding, the sympathetic nervous system is being activated to try and raise the blood pressure. Perforation of the gastrointestinal tract is a risk factor. It's small, and patients would usually complain of abdominal pain, right? Because they're developing peritonitis. And they could also be complaining of bleeding, where the perforation, where the camera perforated the bowel, in particular the colon. They could have some bleeding there, and also abdominal pain, fever, abdominal distension because of an evolving peritonitis. Okay, aspiration. Yeah, if you're putting a scope into someone's stomach, there's a gag reflex there, and if they aren't properly sedated, or if they weren't kept NPO after the procedure, there is a risk of aspiration. Okay. There's also a risk of aspiration if they didn't follow the pre-procedure advice and had something to eat. So not only is that going to make it hard for the provider to look at the stomach because there's going to be food in there, but if they vomit, they're going to vomit up food that they could aspirate. Okay, so aspiration is a concern with an ERCP or an EGD. I mean, it could happen with a colonoscopy, but it's not from the scope. And the reason why I say it could happen with a colonoscopy is you're sedated, you're sleepy, you might get nauseated from the medications, and you could aspirate into your lungs. But it's more commonly associated with upper GI procedures. Okay, so let's talk about barium swallows, which is, well, you swallow the barium, and we look at the upper gastrointestinal system, which is the esophagus, the stomach, and the duodenum. Or a barium enema is where we put barium into the colon, and we take images of the colon, and we get an outline of the colon. So we can get an outline of the upper gastrointestinal tract, called a barium swallow, or we can get an outline of the lower intestinal tract called a barium enema. Now, I'm going to tell you, these are really infrequently done now because scopes are much more accurate, and we can also do procedures during the scope. You can't do any procedure after swallowing barium. It's just diagnostic. There's no procedure that can be done, okay? So it's not as useful. It's really just purely for imaging the upper gastrointestinal or the lower gastrointestinal system. So they really aren't done very frequently anymore. In fact, I haven't seen one in about 15 years. Okay. All right, so how does this work? Well, in terms of the upper GI series, or the barium swallow, it's called, you have the patient drink this liquid radio-opaque solution that has barium in it. And then we take x-rays. And the barium, the x-rays don't go through the barium, so they light up as white. Okay, so on this image here, you can see where the barium is and where it's flowing into the duodenum. Okay, and they can try diagnose ulcers with this and also cancers. Okay. Now, if we want to look at the small intestine with barium, well, all we need to do is wait after someone has drank the barium, and it'll flow through the small intestine, and we can take images of the small intestine as well with X-rays. Okay. So a barium enema is just the other end. We put barium solution into the rectum, and we put enough of it that it goes all the way to the cecum. Okay. So what can we diagnose with these? Well, pretty similar to the scopes, but just not as accurate. Okay. Remember, this is just barium that's lining the wall of the stomach, the duodenum, or the colon. Okay. So we can use it for ulcers of the stomach or the duodenum. We can use it to look for esophageal varices. We can look at for constrictions. So we'll see that the barium can't get through a certain area. Okay, so I don't have as much to say on this because it's just not done very much anymore. Okay. So pre-procedure. So typically these patients are going to be on a clear liquid diet and then NPO after midnight. They're definitely advised not to smoke or take chewing gum because that can stimulate peristalsis, and we don't want more peristalsis. We want the barium to flow just normally through the bowel. Okay. Now the barium enema studies needs to be scheduled before the upper GI. Okay, so why is that? Well, the barium enema, so when we put barium into the colon and we take images, well, that barium hangs around for days after. So now if we do an upper GI series, the barium that's in the colon is going to obscure our view. So we do the upper GI series first, followed by a lower GI series if we want to. Okay. I don't think I'm going to say too much after this. So in terms of post-procedure, so the patient is going to eliminate contrast material. They're going to see it in their stool. So increasing fluid intake is a good idea to promote elimination of this contrast material. Okay. What else is there to mention? I think that's about it. I mentioned that the stools can stay white for a few days, so 24 to 72 hours, as the barium is clearing out of the body. Okay. I think that's all I'm going to mention about this, just because they're just infrequently done now. Okay, so this slide's actually giving you the information on pre and post GI series, right? So so clear diet, clear fluid diet the day before, and then NPO after midnight. Okay. Post procedure, just monitoring for the elimination. It's likely going to happen in the 24 to 72 hours. Increasing fluid intake, and telling the patient that you may see white appearing stool for the first 3 days. Okay. On the right here is an image of a barium enema, right? So the enema solution has been inserted through the anus with barium, and it lights up basically the cecum, the ascending colon, the transverse colon, the descending colon, and you get a decent image. It's just not as accurate as a colonoscopy, and even if you see something, you now have to go on and have a colonoscopy to assess it further. So they've kind of disappeared now because of that. Okay, so let's do questions from chapter 46, I think, in the back. So number 1, a nurse is reviewing a bowel prep using polyethylene glycol. So that's go lightly. That's that 4 liters I was talking about that you have to drink the afternoon and evening before. And typically it starts to purge you of all of all gastrointestinal contents within a few hours, right? So you just can't be too far from the washroom. And how do you know that the polyethylene glycol is effective? Well, I mean, typically after 2.5 to 3 liters, the solution is just coming out of the anus. It's as clear as when it went in. And if you manage to drink the 4 liters, which you really should do, well, it's just clear fluid that's coming out of the anus now, right? The colon has completely been cleaned for proper viewing. Okay, anyways, which of the following instructions should the nurse include? A, check with the provider about taking current medications when consuming bowel prep. Good idea, right? Anticoagulants, antiplatelets, NSAIDs, that's a good idea. B, consume a normal diet until starting the bowel prep. Now, typically you have a clear fluid diet before starting the bowel prep. C, expect the bowel prep to not begin acting until the day after all the prep is consumed. Definitely not. Within a few hours, you know that the bowel prep is working, and you are going to flush everything out. D, discontinue the bowel prep once feces start to be expelled. No. It has to be crystal clear in there. So typically after 3 hours or 3 liters of this polyethylene glycol, you're just having clear liquid coming out of the anus. So the answer is A. Number 2, a nurse is having difficulty arousing a client following a EGD. Which of the following is the priority action by the nurse? Okay, airway. Priority action, whenever I think of a procedure that had some medication, sedatives, IV pain medications, airway, A, B, C, right? Airway, breathing, circulation. Okay, so assess the client's airway. That's going to be the answer. B, allow the client to sleep? No, definitely not. C, prepare to administer an antidote to the sedative? Not necessarily at all. You could prepare a sedative as a rescue, but really it's assessing the client's airway that you want to do. Evaluate pre-procedure laboratory findings. No. Okay, so this person is having difficulty arousing. So the nurse is having difficulty arousing a client. You want to assess the airway. Do they have a patent airway which is open? Do they have good vital signs, including O2 saturation? Answer is A. 3, a nurse in a clinic is instructing a client about fecal occult blood testing, which requires mailing 3 specimens. Which of the following statements by the client indicates understanding? I can't imagine mailing these 3 specimens, but that's what happens, or you just return it to the lab. Anyways, as I mentioned, fecal occult blood testing is used for colon cancer screening at around the age of 45 to 50. Or we can just test someone's stool if we don't see any blood, but we want to see if they have microscopic blood within it. And these fecal occult blood tests will tell us that. Okay, so which of the following statements by the client indicates understanding? I will continue taking my warfarin while I complete these tests. Okay. That's not really accurate, because if you continue taking warfarin and you're spilling just a tiny bit of blood in the gastrointestinal system, it's going to make the test positive. So you're going to get a false positive because of the warfarin. I'm glad I don't have to follow any special diet at this time. Actually, you do have to follow a special diet, because you can't eat red meat, chicken, fish, that can interfere with the fecal occult blood testing, and again, give you a false positive result. Okay. This test determines if I have parasites in my bowel. No, it doesn't. Stools for ova and parasites can determine if you have parasites in your bowel, but not a fecal occult blood test. D, this is an easy way to screen for colon cancer. It is an easy way to screen for colon cancer in the mass population. So the positive people that have positive occult blood tests go on and have a colonoscopy. But really, the gold standard, if someone really wanted to know, if someone really wanted to know the best screening test for colon cancer, it is a colonoscopy right from the start. Okay. Number 4. A nurse is teaching a client who will undergo a sigmoidoscopy. Okay, so it's a short scope that's going to go into the anus and just go as far as the sigmoid. Which of the following information about the procedure should the nurse include? Select all that apply. Increased flatulence can occur following the procedure. Absolutely, because they can still inflate the bowel with air to get a really good view of the sigmoid, right? Just like a colonoscopy, they can inflate the colon. So they can have increased flatulence after the procedure. NPO status should be maintained pre-procedure. So that would be correct. So NPO prior to the procedure. So typically midnight, the night before the procedure. That's accurate. Okay. C, conscious sedation is used. No, not usually. You don't usually need to give someone IV midazolam and IV opioids for this small scope. Okay, it's relatively it's not terribly uncomfortable because it's short and it's a brief procedure. Okay. D, repositioning will occur throughout the procedure. No, that's not true. So the patient will lie on their left side and have the scope. Repositioning throughout the procedure can occur with a barium enema, just to mix the barium all throughout the colon. Okay, so you'll have colon put in, and then they're going to ask you to turn from side to side. So the barium is going to the cecum and the transverse colon and all over the place. Okay. 4. Fluid intake is limited the day after the procedure. That's not true. After the procedure, you should drink fluids, not limit them, right? You can basically start your normal diet and fluids again. Okay, so the answer there is A and B. 5. A nurse is reviewing the health record of a client who has a suspected tumor of the jejunum. Okay, that would be rare. Small intestinal tumors are quite rare, but they can happen. The nurse should expect a prescription for which of the following tests? Blood alpha fetoprotein. No, that wouldn't be for a jejunal carcinoma. Okay. Endoscopic retrograde cholangiopancreatography. No, that's to look at the biliary tree and the pancreatic ducts, right? We put that contrast material into the sphincter of Oddi and get a view of the biliary system and the pancreatic system. C, gastrointestinal x-ray with contrast. Okay, we wouldn't do that now anymore, because if someone is suspected of having a tumor in the jejunum, they're going to go right to having they're going to swallow the pill and have a camera and a visualization of it. Okay, but is it possible to use a barium series, so a gastrointestinal X-ray with barium contrast? Sure, you could, but wouldn't be done very often. Okay, D, small bowel capsule endoscopy. Sure, yeah, that would provide a view of the jejunum. Okay, so a barium swallow would provide a view. Again, we wouldn't do it very often, and the pill cam would definitely provide a view. So C and D so far. Colonoscopy, definitely not, right? We only get to the cecum of the large bowel with a colonoscopy. So it's C and D. Okay, so let's move on to the next chapter on therapeutic procedures. So we're going to talk about nasogastric tubes, orogastric tubes, so a tube that goes from the mouth to the stomach. Nasogastric is from the nose to the stomach. And we'll talk about other ways of providing nutrition, but using the gastrointestinal tract. So we can, for example, use a nasogastric tube to provide feedings for someone short term. But sometimes if somebody requires long-term feeding, but they have an intact gastrointestinal tract, there's other tubes that will be inserted, and we'll talk about some of those, okay? We're going to talk about NG tubes for gastrointestinal obstructions. So say a small bowel obstruction where there's a lot of distension. Sometimes we'll put an NG tube down to decompress the stomach and the bowel. We're going to talk about obesity and some of the surgeries for obesity. We're going to talk about total parenteral nutrition, so TPN. Is a way of providing nutrition to a patient, but not using the gastrointestinal system, right? So it's basically intravenous food. I'm going to talk about a procedure called a paracentesis, where we will drain ascites off of a person's abdomen. So peritoneal fluid that's accumulated to a great extent will drain it off either for as a therapy because the person is so uncomfortable with a distended abdomen from ascites, or for diagnostic purposes. We can send the fluid off and examine the fluid to see if it's infected, to see what kind of fluid it is. And typically, someone with ascites, most often it's from liver failure and cirrhosis, okay? Sometimes it can be from severe congestive heart failure, where the fluid has backed up so much that the liver is congested, and then there's backup of the portal system, and they also get ascites. But most of the time it's from cirrhosis. We'll talk about bariatric surgeries and ostomies as well. Okay, so here's the list. Enteral feeding. So enteral feeding means you're using the gastrointestinal tract for digestion and absorption. So the gastrointestinal tract is working. There's just an issue with getting the food to the gastrointestinal tract, such as difficulty swallowing, following a stroke, say, for example, or a patient that has severe Parkinson's disease and is no longer able to swallow properly and they're aspirating food. Or say a patient with Guillain-Barré syndrome and they're not able to swallow or chew their food any longer. So a whole bunch of conditions that can lead to difficulty swallowing the food, but the gastrointestinal tract is still intact and functioning, and the food just needs to get there. Okay. Total parenteral nutrition, I mentioned, is basically intravenous food, and it's usually used because there's something wrong with the gastrointestinal tract. There's some condition that's causing lack of digestion or lack of absorption, so the patient is losing weight. Maybe they have malabsorption, they're malnourished, so we need to convert to intravenous feeding, which is total parenteral. Parenteral is IV, right? So total parenteral feeding to maintain their nutrition. Okay, a perfect example of TPN years ago was a patient with Crohn's disease. So Crohn's disease is an autoimmune disease that causes patchy inflammation from basically the mouth to the anus. And if it really involves the small intestine, patients used to lose a lot of their small intestine to surgery because of all the bowel obstructions and the inflammation they had with Crohn's disease. and they would end up with short bowel syndrome, to the point where they couldn't absorb enough nutrients to maintain their weight and their health. And what would happen is they'd end up on TPN for a long, long time, for months and months and months, to try and build up their nutrition. Okay, that isn't as common anymore because Crohn's has better medical treatments to control the disease. Paracentesis, I mentioned, is where we put a needle into the peritoneal cavity. So we usually ask the patient, empty your bladder first, because we don't want to put the needle into the bladder. So we have them sitting upright. We freeze in an area in the lower abdomen, since fluid goes down and the bowel floats on top of it. So we look for, with ultrasound, we look at the abdomen and we look for the largest fluid pocket. We freeze the area of the skin, and then we put a needle in and we drain fluid from the peritoneal cavity, and that's for ascites. Bariatric surgeries, we'll go over a bit. Nasogastric decompression, so we can use a nasogastric tube for feeding, so for short-term feeding, so enteral feeding. But most patients don't want to have a tube in their nose for a long period of time for feeding, right? It's uncomfortable. They can get breakdown of the skin, they can get nosebleeds. It's just an uncomfortable tube to have in for a long time. But for short term, we can use it for enteral feeding, or we also use them for decompression in a bowel obstruction. Okay, and we'll talk about that. And then we'll briefly talk about ostomies. Okay, so enteral feeding. And remember, enteral feeding just means you're using the gastrointestinal tract. So whether that's through the nose or through the mouth with a tube, or into the stomach with a tube, through the abdominal wall and into the stomach, or through the abdominal wall and then putting a feeding tube into the jejunum. And you'll see images of all of them. So it just means that we're still using the gastrointestinal tract because it's fully functional. And when we're feeding a patient, it's definitely beneficial to provide feedings through by using the gastrointestinal tract, because that's how we're made. The gastrointestinal tract is meant to be used. Okay, so it maintains the proper what's called the microbiome of the bowel, so the bacteria. It keeps the bile flowing, it keeps the pancreatic juices flowing. So everything is working fine. We just have to get the food there, because there's some kind of difficulty that's stopping the person from swallowing, eating, chewing, getting the food to their stomach. Okay, and I mentioned some conditions such as strokes, Parkinson's, Guillain-Barré, myasthenia gravis, all kinds of conditions. Okay, maybe someone had cancer of their larynx or their throat, and they're unable to swallow properly anymore. So there's all kinds of reasons to bypass the area, and typically for long-term feeding, we'll put a tube through the abdominal wall, so a G tube or a J tube. I'll show you some images for long-term feeding. Okay, and enteral feeding has much less complications than parenteral. So then parenteral feedings, which is called TPN, right? Because we're using the proper way that the body's used to digesting and absorbing. Okay, so what are the reasons? I mentioned some of them. So an inability to eat. So say someone is comatose or they're intubated for a prolonged period of time. Now, they're going to start to lose weight. They're going to need nutrition, right? Someone who's at risk for aspiration. I mentioned before, strokes, Parkinson's, maybe someone with severe MS, or someone who has tremendous metabolic demands and they're not well enough to eat. So in the short term, someone with a severe burn, and they're intubated. And they may be intubated for days, weeks. They may not be able to maintain enough caloric intake, so they get a feeding tube. Okay. Someone with sepsis, which is typically a bacterial infection causing systemic inflammation throughout the body, abnormal vital signs, they're really sick. They're typically in the ICU getting IV antibiotics, and they may need a short-term feeding tube, so a nasogastric tube. Okay, so no one's going to go to the effort of putting a long-term feeding tube in through the abdominal wall if we know it may be just days or weeks, compared to someone who's had a severe stroke or Parkinson's, and they likely will just require a long-term tube through the abdominal wall. Okay, and I'll show you some images coming up. Okay, so let's look at some common uses of typically nasogastric tubes. But if we can't get a tube to go into the nose and down into the stomach, we can always go through the mouth and into the stomach. So most of the time they're nasogastric. Okay, so here are some reasons: decompression and drainage of the stomach and the small intestine. So someone with a bowel obstruction, right? So proximal to the bowel obstruction, there's gas, there's fluid that just can't pass the obstruction. So the patient is very uncomfortable. They're distended, they're nauseated, they're vomiting. So sometimes we'll put an NG tube down to suction out the fluid and the gas. And this is typically accomplished by suctioning with pressure. So applying negative pressure to the NG tube to get the fluid out. And we monitor the amount of fluid that we're suctioning out of the gastrointestinal tract, because we often have to replace that amount of fluid in the form of IV fluids. Otherwise, they'll become dehydrated, right? So decompress and drain the stomach and small intestine. Sometimes we can use an NG tube to aspirate, just to take the contents of the stomach to analyze them. Okay, that's not done very often, but we can do that by putting an NG tube down and just aspirating some fluid. Gastric lavage is where we put a tube down and we can suction up. We can potentially suction up a lot ingested poisons or other harmful products that people have ingested. And we can also lavage, meaning we can flush out their stomach with large volumes of fluid. So not only can we suck up ingested material, but we can also lavage the whole gastrointestinal tract with fluid through this tube. Okay. Enteral feedings. So the next one, administration of enteral feedings. This is an option, right? It's typically a short-term option. We'll talk about other options coming up. But enteral feedings can definitely be provided this way. Fluids can be provided this way, and medications can be put down the NG tube. Okay. The next one is a particular type of tube. So don't just think it's a straight tube that goes into the stomach. This tube is used for esophageal varices. So it's called a Sengstaken-Blakemore tube. It's this large tube that has inflatable areas in the esophagus and an inflatable area for the stomach. Okay, so someone has bleeding esophageal varices from liver cirrhosis, and they're just dripping, just pouring blood into the stomach. So how can we stop this bleeding quickly? Because the patient is likely hypotensive, tachycardic. They're losing tremendous amounts of blood. So there's this tube we can stick down, and we insert it so that the esophageal balloon is in the distal esophagus, and the stomach balloon, they haven't been inflated yet, is in the stomach, and then we inflate them. And what that does is it compresses the bleeding esophageal varices, which are basically veins that are bleeding, right? So that's a particular type of tube. So don't confuse it with just the average NG tube that we're suctioning material out of, or we're providing enteral feeds. Okay, so that's the compression one. So compression of a bleeding site, and the bleeding site is going to be typically esophageal varices. Okay, so let's just look at some different tubes. So we can use the term gastrointestinal intubation, which really just means that we're putting a tube, whether it's in the mouth or in the nose, into the gastrointestinal system. So let's look at the types a bit. So typically they're just named by where they start and where they end. So the Salem pumps are really for suctioning. So we've spoken about the nasogastric tube and the orogastric tube. And these have 2 lumens, okay? So the first lumen is to suck up material, right? The second lumen is to allow air to go down to make it easier for the suction to work and to suck up material. Okay, so their main role is for gastric suctioning and decompression. Could they be used for feeding or administering medication through? Sure, they could, okay? So let's go and look at the next one. So we looked at gastric tubes, nasogastric and orogastric. So enteric tubes. So it's the same thing. Whether it's nasoenteric or oroenteric, it's just telling you where it began, so in the nose, naso, and where it ended. And some of these end in the small intestine, typically the jejunum. I would try not to get too confused with these because basically you can feed through a nasogastric tube, you could feed through an orogastric tube, or one of these enteric tubes that starts in the nose or the mouth and ends in the jejunum. So we'll call them nasojejunal or orojejunal, okay? Remember, we also have ones that go through the abdominal wall, the gastrostomy tubes, and we typically call those percutaneous endoscopic gastrostomy tubes, so PEG tubes, okay? And there's also jejunostomy tubes, which again goes through the abdominal wall, so it's percutaneous, it's endoscopic, and it's going to the jejunum, okay? Okay, so let's go into the placement of an orogastric or a nasogastric tube, okay? So the first thing is, do we really need to do this? These are uncomfortable, okay? Patients don't like them, they don't like them being inserted, and they don't like having them once they're inserted because of the discomfort. So the first question we ask is, does this patient really need them? And then we ask the patient, do you want to try a nasogastric or an orogastric tube, okay? And typically, as I mentioned before, it's for a mechanical obstruction, so a bowel obstruction, say from adhesions that have caused twisting of the small intestine, or there's a tumor that's obstructing the small intestine, or say they have a strangulated hernia that's causing small intestinal obstruction, anything that's caused obstruction of the small intestines, okay? Or anything that's caused lack of peristalsis to the small intestine, so post-surgical. Say someone's had a severe illness and peristalsis is turned off. Whenever you get really, really ill, say with sepsis or a significant burn or trauma, you can have a paralytic ileus. So your bowel stops with peristalsis. And that also happens after abdominal surgery, where the peristalsis has temporarily shut down. The bowel has shut down, and it needs time to recover. And during that time, some patients have a lot of abdominal distension, nausea, and vomiting, and they can be a candidate for a nasogastric tube. Okay, so how do these people present? Well, typically they come in and they're vomiting, right? They're distended. If it's in the case of a post-surgical patient, they probably don't have any bowel sounds because it's a paralytic ileus. It's the bowels just turned off. And so the gas can't move, the fluids can't move, so they're just distended, they're vomiting, and that's a reason for putting in an NG tube. If it's someone who has an obstruction, say a small bowel obstruction from adhesions, they typically have, they're distended, they're vomiting, they're uncomfortable, but they have high-pitched bowel sounds. It almost sounds like the sounds of being within a drum. So it's bowel sounds, but it sounds like they're echoing in a drum. And that's because the small intestine is dilated and distended, and the sounds it's making really sound like they're echoing in a drum. Okay, and that's called hyperactive, high-pitched bowel sounds. Okay. Someone with a bowel obstruction typically has this colicky central abdominal pain. They're uncomfortable. Their abdomen is really distended. Okay, so assessing the need for sure. Advising the patient of what's going to happen prior to putting the tube in, right? It's really nice for the patient to know prior to putting in this tube. Okay, so how do we put these tubes in? Well, so the nurse or the physician put in NG tubes frequently, okay, and we do a measurement. So we take the tube and we measure from the nose to the earlobe, and then we measure from the earlobe to the xiphoid process, which is right at the end of the sternum, and that's about the length. So we'll mark off that length on the tube, and we'll decide, okay, it's whatever, 25 centimeters or whatever length it is, and we'll put the tube in until we reach that mark. Okay. So what else do we do before putting in this tube? Well, often we'll spray some lidocaine into the nose to numb it a bit. Sometimes we'll put in a decongestant, such as phenylephrine, just to shrink the tissue down a bit in the nose, just to make it a bit more comfortable for them. Okay, we'll lubricate the tube. Okay, and then we'll slowly guide the tube along the base of the nose. So we don't point the tube upwards in the nose towards the brain. Okay, we go horizontally in the left or the right nostril. So once we have the tube length, we've lubricated the tube, we'll make sure that there's a glass of water at the bedside, and once we start to put the tube in, it's going to go to the back of the nose, going to be uncomfortable, and then typically it slides down, and it slides down the pharynx and heads towards the esophagus. Okay, we get them to drink water with a straw while we're inserting this, because the swallowing action helps guide the tube into the esophagus. Okay, and that's where we want it to go. Okay, we usually have them slightly flexed, so chin to chest, slightly flex, the neck flexed, swallowing with a straw, and insert into the esophagus. Now, if it happens to go, through the nose, no problem, and then sometimes it'll coil up in the mouth, and you'll have the patient open the mouth, and you can see the tube all coiled up in the mouth. So we remove it and do it again. If it goes anywhere near the trachea, the patient is coughing and sputtering, and they can't tolerate it at all. Okay, and then of course we'll pull that out as well. Okay. checking placement. So how do we check the placement of this tube? So we can attach a syringe to the end of the tube and try and aspirate gastric contents. So we'll see gastric contents coming up the tube. The other thing we can do is we can fill a syringe with air and we can attach it to the tube and compress the syringe while we're listening to the stomach, and we'll hear the air bubbling in the stomach. So we can do that. Okay, but we always get a chest X-ray. Okay, so we either get a chest X-ray or an abdominal X-ray to see exactly where the tube is in the stomach. Okay, and if it needs adjusting, say it hasn't quite gotten into the stomach, it's still in the distal esophagus, because the tube is radio opaque. It appears on the X-ray. So we can, if it's still a bit too high, we can put it in a bit more until it's in a position in the stomach that we're happy with. Okay. So we want to maintain the proper location of the NG tube. So we typically tape it to the nose, to the nostril, right? So that it's stable, and then we can apply suction to the NG tube if it's being used for decompression of the stomach. Okay. Remember, the fluids that we take out of an NG tube while we're decompressing, say, a bowel obstruction, we have to monitor the output of that, because we have to add it to their overall IV fluids in terms of total amount of fluids they need. Otherwise, they won't be getting enough fluids, right? Okay, so we also have to monitor electrolytes. So we're suctioning fluid out of the gastrointestinal system, so they're going to need their electrolytes checked, right? And also checking the nose, right? The nose gets really irritated with these tubes that are rubbing along the nostril. Okay. Okay, so management of nasogastric tubes. I'll call them nasogastric tubes since they're the most common ones compared to an orogastric tube. So rinsing, basically flushing the tube before and after each use with 30 mils of sterile water or saline. Okay. Also flushing with at least 5 milliliters after each medication. So you may have multiple medications, but they should each be flushed after administering the medication in an NG tube. Okay, and the medication really needs to be dissolved in fluid before putting it in the NG tube. Monitoring ins and outs, we mentioned, right? So if we're using this as a suction to decompress the stomach, we really have to monitor the output. Okay, if we're using it as enteral feedings, well, we're definitely going to monitor the amount of feedings or fluid that's going in the NG tube and their urine output. So it just depends on what we're using it for. Okay, sometimes they become obstructed, and a 3 ml syringe is used with an adapter that fits onto the NG tube, because a 3 ml syringe doesn't fit on an NG tube, so there's an adapter. And we can try and break up the clot, say with just a little bit of TPA in there. Now, we typically don't use Coke. I know Coke has been used in the past. Typically, it's not used very much anymore. So we used to instill a bit of Coca-Cola and let it sit and hopefully, fizz and break down whatever's causing the obstruction. That's not done so much any longer. So sometimes what we'll do is we'll just put some warm water in a syringe. So in a 60 ml syringe, and we'll just gently try and unblock the obstruction. Okay, we won't force it with full strength. Okay, that wouldn't be a good idea because the NG tube might just break open somewhere. Okay, so just gently pushing and pulling the plunger sometimes just breaks up the obstruction. Okay. The other thing is we can also just put the warm water in and let it sit there, and hopefully it just soaks whatever's obstructing it, and then it clears up. Okay, so also don't forget about the nasal hygiene and checking for skin integrity, because often they can get inflammation where the NG tube is rubbing against the nostril. Okay, and lastly, a bridle, so a nasal gastric tube bridle. That's just a way of securing the nasogastric tube, because often they become dislodged, right? So it gets caught on the bed, someone moves, and suddenly, before you know it, the nasogastric tube has been pulled out, and now the patient has to endure the insertion of another one. So it's just a way of securing the nasogastric tube. Okay. Okay, so let's just look at some percutaneous tubes that go through the abdominal wall. So a gastrostomy, or what's called a PEG tube. So what's a PEG tube? So a percutaneous endoscopic gastrostomy tube. Okay, so it goes through the abdominal wall and into the stomach. And this is definitely preferred for administering of medication and for feeding in patients that will likely require it for long term. Okay, so this is placed surgically or endoscopically in the radiology suite. So a jejunostomy is a tube that goes through the abdominal wall. Again, it's placed surgically, and it is inserted into the jejunum, and this reduces the risk of aspiration, because you're putting the feeding tube further down. So compared to a gastrostomy, where the food is being inserted into the stomach, there's a higher risk of aspiration. So by inserting it lower down into the jejunum, there's less risk of reflux and aspiration. Okay, so remember, these tubes are for long-term administration of nutrition and medications, since NG and OG tubes are really only meant for the short term, days to weeks, typically up to 30 days. And then if a tube is still required, they're converted to a gastrostomy or a jejunostomy. Okay, and the last one is just a variation, right? So a GJ tube is one that goes through the abdominal wall. It's inserted into the stomach, and then the tube is feathered down into the jejunum. Okay, so it gets into the stomach, but then the tube is pushed further down until it arrives in the jejunum. Okay, so let's look at some complications of enteral feeding. Okay, so the first one would be overfeeding. So there's just too much volume of fluid that's getting into the stomach or the jejunum. Okay, and that's causing some abdominal distension, nausea, and vomiting. Okay, so how can we know this is occurring? Well, we can check a residual volume check. Okay, so that's just a matter of aspirating from the tube. So say from the G tube or the J tube, aspirating and see what volume is left in the stomach or in the jejunum. And if there is a residual volume of 100 milliliters to 200 milliliters, then it's just a matter of holding the enteral feeding and restarting it at a slower rate. Okay, so residual checks aren't always done in every facility. If they are done, they can be checked every 4 to 6 hours to see what the residual is. Usually people will complain of symptoms, right? The abdominal distension, the nausea, and vomiting, which makes sense because their intestines are filling with the nutrition. Underfeeding, well, that would make sense if someone isn't getting enough caloric intake to maintain metabolism of their body, then they're going to start to lose weight, right? So they may complain of hunger, but really we're going to be monitoring people's weights when they're on enteral feeds to make sure that they're maintaining proper body weight. Okay, so diarrhea is another one, and this can be caused by either the patient isn't agreeing with the formula that's being used, so the enteral feeding formula, or it's going in too fast, or potentially some medications that are being used, right? So it's a matter of, again, of slowing the rate to see if the diarrhea settles, allowing for more digestion and reabsorption. Sorry, not reabsorption, absorption of the nutrition. Okay. If the diarrhea were to really persist, we'd start thinking of infectious causes. Okay, especially if they're on antibiotics, such as Clostridium difficile. Okay, constipation while on enteral feeding, that's likely due to reduced fiber intake, but it can also be due to reduced volume, right? So reduced volume of fluids, the body will want to keep all of its fluids, and it'll cause constipation. Right? So the stool will become really hard because the body's taking all the fluids out of it. And if someone's on any kind of opioids, this is really constipating as well. So constipation is almost universal when patients are taking opioid medications. Okay. Aspiration pneumonia is another complication. So it could be due to the placement of the tube or the fact that the patient is lying supine in bed. So really to prevent this, because these tubes can still get misplaced, right? They can still dislodge and move. So how can we prevent aspiration pneumonia? Well, sitting the patient up in bed by at least 30 degrees during the feedings and also after the feedings for 1 or 2 hours. Confirming the tube placement before feedings. And if we suspect that there's aspiration pneumonia or there's reflux of the food, then stop the feeding, right? As well, if we suspect that there's aspiration, it would be a matter of, especially if the person's comatose or decreased level of consciousness, suctioning the airway, checking vital signs, and now we're going to follow them for fevers. Because if you develop an aspiration pneumonia, you're typically going to develop a fever with it, right? And shortness of breath. When we listen to the lungs, we may hear crackles or crepitations, which is an indication of pneumonia. Okay, and then if we really suspect someone is has developed an aspiration pneumonia, we'll do a chest X-ray to confirm it. The next one is refeeding syndrome, and this is typically in someone who's really malnourished and the body just hasn't seen proper nutrition for a long time. So it could be in someone with severe depression that hasn't been eating, substance abuse, an alcoholic, someone with anorexia nervosa that hasn't been eating and they're highly malnourished. And it's caused by the introduction of enteral feeds, right? And it can cause massive shifts in electrolytes and be life-threatening because of that. Okay. So I would think of refeeding syndrome as a patient who hasn't had proper nutrition for a long, long time, and now the introduction of enteral feeds has caused the body to shift and start processing all this, all these carbohydrates, proteins, and lipids, and it's causing massive shifts of fluids and electrolytes in the body that can become dangerous. Okay, so sometimes we have to give these patients vitamins such as thiamine. We have to monitor their electrolytes. Often their magnesium and potassium and phosphate are really depleted, so they have to be added and also closely monitored. Okay, so I would think of it as a body that just hasn't seen nutrition for a long time, and now it has to suddenly turn on and start using all of these electrolytes for to metabolize the nutrition that's coming in. Okay. Okay, so fluid volume deficits. Well, if someone's not getting enough overall volume of fluid, they're going to gradually become deficient in fluid, right? They're going to gradually become dehydrated. So the best way to monitor for this is input and output. So how much fluid is this person consuming over a period of time, and how much output is this person giving out, right? In terms of urine output. So that's why ins and outs are so important, to monitor for overall fluid volume. Okay, and let's look at the last one, dumping syndrome. So dumping syndrome can occur with a few conditions. So if someone's had some kind of bariatric surgery where there's been a change in the anatomy of the gastrointestinal tract, they can develop dumping syndrome. For example, if someone's had part of their stomach removed, well, when they eat food, the food cannot be stored in the stomach because part of the stomach is missing, and a large volume of food ends up in the small intestine, and it leads to something called dumping syndrome. This can also occur with enteral feeding. So the high osmolarity or osmolality of the solution that's being administered for feeding pulls water out, or pulls fluid out of or pulls fluid into the gastrointestinal tract, right, from the cells. And this causes a number of symptoms. So if you can think of this hyperosmolar fluid that's being used for feeds, it pulls fluid out of the gastrointestinal cells, and it leads to bloating, nausea, vomiting, abdominal cramps, diarrhea. The patient can be flushed. They can feel dizzy, and they can have a rapid heart rate, all because the fluid is being sucked into the gastrointestinal tract to try and dilute this hyperosmolar fluid that's being administered. So I would just think of this as a complication of, well, typically a gastrostomy tube, where we deliver fluid into the stomach, so enteral feeds into the stomach, and they suddenly just flow quickly into the small intestine, causing these fluid shifts that cause increased volume of fluid in the small intestine. So it's going to cause local symptoms of bloating and diarrhea and cramping. But because it's taking fluid out of the systemic circulation, they can also become tachycardic, dizzy, and flushed. Okay, before I go to parental nutrition, I just wanted to mention in terms of dumping syndrome, So I mentioned dumping syndrome can occur with enteral feeds, but it also can occur with uh, uh, surgeries that have removed part of the stomach. Okay, and what happens is the food is delivered really quickly to uh, the small intestine, and it causes these fluid shifts and all the symptoms I mentioned. So, how do we prevent dumping syndrome, say, after someone's had a partial gastrectomy, or even with enteral feeds as well through a feeding tube? So, the first one is um, having smaller meals through the day. So instead of having 3 big meals, having 5 or 6 small meals. This will allow less um, food to be introduced into the small intestine, causing less fluid shifts. Okay. Also limiting carbohydrates. Okay, so baked goods, a lot of carbohydrates will cause the fluid to shift even more. So you want to limit um, uh, carbohydrates in the diet. Okay, so instead, eating more protein, such as meats, chicken, fish. Okay, they don't tend to cause the big fluid shifts like carbohydrates do. Increasing fiber in the diet is going to help as well, and also not to drink fluids um, within 30 minutes of your meal. Okay, so 30 minutes before your meal and 30 minutes after your meal, because the fluids will cause more abdominal distension and more discomfort. Okay, so not eating with, or sorry, not drinking with the meal. Okay, so let's just talk about TPN a bit. So, uh, parenteral nutrition, and really this is giving nutrition through an IV, right? And it's usually done because the gastrointestinal system is not functional, or the patient has some kind of disease or trauma where they need even more, they require more nutrition to maintain their metabolism. Okay, so TPN is usually administered through a central line. Okay, and it's it's a complete nutrition. It's high in calories. It consists of dextrose, usually in the range of 10% all the way to 50%. It has lipids, fatty acids, electrolytes, protein, vitamins, and trace elements. Okay, so it's really meant to replace uh, uh, regular eating. Okay, since someone is unable uh, to to um, to to eat food. Okay. So what are the indications for this? So it would be in a patient who is unable to either digest or absorb food from the gastrointestinal tract, some kind of hypermetabolic condition, such as a severe burn, where they just can't maintain nutrition and they need so much calories to heal the burn. So let's look at a couple of conditions. So pancreatitis, where they're not making um, uh, proper proteases and lipases to digest the food. They may require TPN. Okay. Short bowel syndrome I mentioned before. That's where segments of the bowel have been surgically removed, or they're just not functional, and that causes a decrease in the surface area for absorption. So they're malnourished because of that. Okay. Severe burns I mentioned. So that's because of hypermetabolic state where and the person just can't consume enough food, and often they're not well enough to consume food, so they may require TPN to maintain nutrition. So, uh, starting TPN usually involves a dietary consultation because everybody is individualized in terms of what they require. Some of it will be based on the disease process. some of it will be based on their blood work. Okay, I'm not going to go into too much detail. I'll just say a couple of things. So remember the TPN can only be left for 24 hours. So the bag and the tubing has to be replaced. Okay. There's typically a filter. So the tubing has a filter to collect any small particles that are within the solution. We don't use the line for other IV administration, so it's a dedicated line for the TPN. Monitoring of glucose. So because TPN is high in glucose, monitoring of glucose every 4, 5, 6 hours to see if they are becoming hyperglycemic in the first 24 hours, right? So, and if they are becoming hyperglycemic, some patients will need insulin to control their high blood sugars, okay? Typically, we'll have dextrose at the bedside, and the reason for that is if the TPN were to stop being administered or it ran out, well, what's going to happen? So there's no more TPN going into the system, but the insulin in the body is elevated because it's been processing the glucose that was in the TPN to keep it at a low, to keep the glucose under control. So if the TPN suddenly runs out and the insulin is at a high level, patients can become hypoglycemic. Okay, so in order to treat that, we need a dextrose solution such as D10 at the bedside to treat potential hypoglycemia. Okay, the same would apply if a TPN bag is running low and you don't have a replacement. Well, you may have to, when that bag finishes, you may have to hang D10 to continue glucose administration so they don't become hypoglycemic. Okay, so these are this slide is just showing you different access points to administer TPN into the venous circulation. So temporary catheters, so those are your central lines such as your internal jugular, subclavian, your femoral line. They're not really meant for long term, and they can be inserted at the bedside, but they have the highest risk for infection, right? So if someone were to be on TPN for prolonged periods of time, it would typically either be a PICC line, so a peripherally inserted central catheter, or one of the long-term central venous catheters, such as a Hickman catheter, or a portacath can be implanted in the chest. Okay, so I won't go into too much detail on this slide. Okay, in terms of possible complications of parenteral nutrition, well, you can definitely have metabolic complications because you're actually putting food right into the venous system, right? It's not going through the gastrointestinal tract. It's not being processed by the liver. So you can run into issues with hyperglycemia if, say, too much TPN were being administered or the patient just can't tolerate the load of glucose that's being administered. You can develop hypoglycemia if the TPN were to suddenly stop being administered and insulin continues to function in the body, leading to hypoglycemia. Vitamin deficiencies can occur because the exact amounts may not be adequate for the patient. So everyone's a bit different, and that's why blood work is typically closely monitored and fluid volume is monitored. Okay, so remember the monitoring of sugar for hyperglycemia and the fact that they may need insulin temporarily. Okay, and if someone were to need more fluids because the TPN isn't administering enough fluid volume, Well, we can put in a separate IV and give them an isotonic solution, such as lactated ringers or normal saline. So it's just a matter of putting in a second IV line. So an air embolism, well, that can occur with any line that's inserted into the venous system. And what are symptoms of an air embolism? And it usually has to be a significant amount of air. So sudden onset of shortness of breath, chest pain, anxiety because they're short of breath, and hypoxia, right? So a low O2 sat. How do we treat it? Well, if we think there's an air embolism from the IV line, whether it's from TPN or anything else, we can clamp the catheter, we can turn off the flow if we think there's air in it. We would position the patient on their left side and put them in Trendelenburg, so their head is going down. And what does that do? So if you think about it, if you lie someone on their left side and you put them in Trendelenburg, you're basically trapping the air to the right side of the heart so that it's not being pumped into the lungs, leading to all these symptoms. And the air will gradually be reabsorbed by the body. So the body will take care of it, but that's the position that we put people in. And of course, administering oxygen. Infection can definitely occur because there's glucose, there's nutrients in the TPN. Okay, so it's a good place for bacteria to potentially grow. So just assessing the central line insertion site for any redness or discharge or swelling, changing the sterile dressing at the insertion site of the central line, and that's typically done every 2 to 3 days. And also vital signs and monitoring the patient for any signs of inflammation and infection. So that would be fevers, elevated white blood cell count, chills, rigors, malaise, all of those symptoms where we think, okay, there could be an infection occurring here. Okay, and just remember the TPN line is not used for other IV fluids and medications. Okay. Okay, the next one is fluid shifts. So we're giving a hypertonic solution, right? So it's hyperosmotic or hypertonic. So it's going to cause shifts of fluids into the intravascular space. So who doesn't do well with shifts of fluid into the intravascular space to try and dilute this TPN? Well, it's going to be older patients, right? They could become fluid overloaded. So how do we assess this? Well, we're going to ask them if they're short of breath. We're going to listen to their lungs to see if they have crepitations or crackles in their lungs, which may indicate fluid excess that's building up in their lungs. We're going to monitor their weight daily and also their input and output. Okay. And typically with TPN, we gradually increase the flow rate. Okay, we don't go right to the flow rate that's desired. We gradually get there to minimize fluid shifts. Okay, in terms of discontinuing the TPN, this has to be done very gradually. Okay, because as we slow down the TPN, if it's too abrupt, the sugar will stop being administered into the body since we're stopping the TPN abruptly, but the insulin will be still at a high level in the body and lead to hypoglycemia. Okay? So we do it very gradually to allow the body to adjust to a lower load of glucose in the TPN as the flow rate is declining. Okay? And remember, having IV dextrose at the bedside in case the TPN either runs out or the line becomes kinked and there's no TPN being administered and the patient may become hypoglycemic. Okay, so this is more of just a reminder and just some images. So nasogastric decompression. When would we do that? Typically for a bowel obstruction, okay, to decompress the stomach and the upper intestines, okay. And if we can't get it through the nose, say somebody has a deviated septum, or they don't tolerate the nasogastric tube, we can always use an orogastric tube, okay. So for this procedure, we usually tell the patient this is going to be uncomfortable. We're going to try and make it as comfortable as possible, sometimes by spraying the nose with some lidocaine spray. And this is done either by the nurse or the doctor. They typically sign a consent for a nasogastric tube insertion since it's a procedure. Okay, patient sits in high phallus position. We do the measurement from the nostril to the earlobe, and then down from the earlobe to the xiphoid process, and we add them together, and that's usually around the distance. Remember, the distance is, or the positioning is confirmed not only by suctioning gastric fluids with a syringe, but also we'll do an x-ray to look at the position of the tube, okay? When we're inserting this into the nose, the patient is sipping water, typically. We give them a little glass of water to sip on so that it helps swallow with the tube, okay? We never force the tube. If it's in the nostril and stuck because there's something blocking it, we never force it because it makes the nose bleed, okay? And I think that's it for this slide. Okay, so let's move on to another abdominal procedure, and that's called paracentesis. And paracentesis is used to remove fluid in ascites, right? So ascites is a collection, a large collection typically, of peritoneal fluid. Okay, so the peritoneal cavity is the cavity where the intestines live, and this cavity can fill with liters and liters of fluid. Okay, so what's the most common cause of ascites? Well, typically it's liver failure or cirrhosis. Sometimes it's from metastatic cancer that has spread to the liver and is now causing liver failure and backup of fluid in the portal system and causing ascites. Okay. So most of us don't have ascites. Okay. Most of us might have a bit of peritoneal fluid that is really not noticeable. But with ascites, patients become really uncomfortable. Okay, it's hard to breathe, it's hard to lie down because the abdomen is so distended with fluid. Okay, so putting someone supine with ascites makes them short of breath. Okay, there's a lot of weight gain, since if you see in this image here, that is all fluid. So patients put on a lot of weight because they're carrying around all this excessive fluid. So ascites fluid tends to be protein-rich fluid, and what we want to do with a paracentesis, well, there's two reasons for doing a paracentesis. There's a diagnostic paracentesis, where we want to remove the fluid for diagnostic purposes, so we can send the fluid for examination. We can see the amount of protein in it. We can send it for a culture to make sure that nothing is growing in the peritoneal fluid, since that's a very serious condition. If you have bacteria growing in your peritoneal fluid, well, we call that peritonitis. Okay, so sometimes we'll send it for a culture and sensitivity to make sure there's no infection. The other reason for doing a paracentesis is for symptomatic treatment. Okay, so diagnostic and also therapeutic. Okay, so the therapeutic part is the patient is so uncomfortable sitting up with this or lying down with this because they're so short of breath that we're going to remove fluid with the paracentesis. So typically we provide the patient with information of what we're going to do, and it usually involves using an ultrasound in the emergency room. This is often done in the emergency room. It can be done in an outpatient setting, so it doesn't need to be done in the operating room. Okay, but we give them an idea that we're going to look at their abdomen while they're sitting upright as much as possible, and looking for fluid. So looking for the best pocket of fluid where we can then mark the skin, put the freezing in, and we put the lidocaine in not only to the skin, but we go deep with the lidocaine freezing all the way to the peritoneal lining, because that peritoneal lining is exquisitely painful. And we freeze the whole tract, okay, just with local anesthetic. They typically have to sign a consent, right, that they agree to this procedure. We always have them, so before they're ready for this procedure, they need to fully empty their bladder so that the bladder is not full of urine, and there's a potential to poke the bladder with the paracentesis needle. Okay, so we have them empty their bladder. We have them sit upright as much as possible in a high Fowler's position. And vitals are taken. Okay, we check their vitals. We check their weight. Sometimes we'll measure their abdominal girth. Okay. And then sometimes we'll provide them with sedation. Most of the time, patients don't need sedation if there's really good local anesthetic. We typically will then take our paracentesis needle and carefully put it through the frozen, the anesthetized tissue while we're pulling back on the syringe. And we're just putting it through very carefully while pulling back on the syringe until we get peritoneal fluid back. Okay. Once we get peritoneal fluid back into the syringe, we attach the catheter to a tubing system that then is going to allow the fluid to drain. Okay, and many liters can come out. Okay, so don't typically give sedation that often, but we do give albumin typically after the procedure. Okay, why do we give albumin? Well, patients with liver failure or cirrhosis or metastatic cancer to their liver, they're not making albumin very well anymore. So their blood vessels are leaky because they've lost oncotic pressure. So we can slow down the return of the ascites by giving IV albumin to provide them with some oncotic pressure. So during the procedure, we just let the fluid drip out. Okay, we usually go after fluid which is in the lower part of the abdomen, since when they're sitting upright, that's where the fluid is going to be, right? So we want as much to flow out. And different hospitals and different healthcare providers just allow different amounts of fluid, so peritoneal fluid to drain out. So some will allow 4 to 6 liters to drain out. Others will allow many more liters to drain out. The issue with draining large volumes of ascites is that they can become hypotensive because we're really draining fluid out. And what's the body going to do? Just try and replace that fluid that's in the peritoneal cavity with more fluid, since we're relieving the pressure from it. Okay. So it's just draining out by gravity. It can often take half an hour or an hour to drain out. And we measure the amount of fluid that's been drained out, right? And as I mentioned, we're giving them intravenous albumin to try and provide them with some oncotic pressure uh, in their vascular system. Once we've removed the fluid amount that we'd like to remove, so say it's 4 or 5 or 6 liters, for some people it's 10, for some healthcare providers it's 10 liters. Once we've removed it, then we can stop the flow and remove the needle. And often, because there's still fluid inside the abdomen, but they're definitely much more comfortable now, there's still a bit of leakage from the site that we punctured. So sometimes we need to put pressure on that, and actually sometimes we need to put a stitch in it to stop it from just oozing clear peritoneal fluid. Okay. So their vitals are checked frequently after the procedure to make sure that they don't become hypotensive. Okay. We're going to monitor their temperature, and we're going to tell the patient to return if they have a fever in the next few days, because there is a small chance when we put a needle into someone's abdomen that we introduce bacteria, and then they can get infected ascites, which is peritonitis. Okay. To try and slow down the return of the ascites, I mentioned giving intravenous albumin during or after the procedure. That can slow down the return of the fluid. But also we can give diuretics, such as furosemide, or another one that's commonly used, spironolactone. Okay, and it might just slow down the return of the ascites so they don't have to have a paracentesis as frequently. Okay. Now, typically patients after this procedure are really content because they can breathe easier and it doesn't feel like their abdomen is under so much pressure. Okay. The fluid itself that we've allowed to drip into a, say, a bag or a bottle, we always look at the color of it, the consistency. We like to see that it's kind of a straw yellow color. Okay. And while they're in the department, so the emergency room, we're monitoring for hypotension. We're monitoring if they're dizzy, if they have an altered mental status from low blood pressure. And we'll check the site of insertion to see if it's continuing to leak. Okay. Now, anyone who has liver failure, in terms of educating them, well, with or without ascites, ascites is just an indication that the liver failure is quite advanced. So, again, we're going to remind them, minimize or avoid alcohol completely, have a low sodium diet, since a low sodium diet is not going to cause them to be thirsty, and drink fluids, which is important because when they drink fluids, some of it's going to produce ascites. Okay, and also monitoring the puncture site when they go home. Okay. It's also important to remind them that when they go home or back to their hospital bed, that get up very slowly. Okay, we've just removed 4 or 6 liters from your abdominal cavity, so you can have orthostatic hypotension if you get up too fast. Okay, and that's partly why we give albumin. Okay, to maintain that oncotic pressure, but they can still have significant fluid shifts and have orthostatic hypotension. Okay, so let's look at the complications. Well, anytime you have an invasive procedure in your abdomen, always think of infection. So we put a needle into the peritoneal cavity. There is a risk of introducing bacteria. It's a low risk since it's a sterile procedure. Okay, but we always tell them to monitor for fevers. Hypotension or hypovolemia can absolutely happen because we've removed 4 to 6 liters. Remember, your blood volume, your entire blood volume as an adult is 5 liters of blood. So when we remove 4 to 6 liters of ascites fluid, you can have fluid shifts and cause hypotension. Okay. So what would we do for hypotension? Well, we can give them IV fluids, which isn't a great thing to do because some of those IV fluids will go into producing more ascites. Or we can give them a volume expander, and we mentioned one of those. That's albumin. Okay, that's going to expand the intravascular volume and help prevent hypotension. Okay. We always warn people that if you have a continuous leak from the site where we punctured and did the paracentesis, we may have to put a pressure bandage on it or actually put one little stitch in it to stop it from leaking. Okay. If they get a really tender abdomen or fever, that can be an indication of peritonitis. They need to come back and see us. Okay, so we've discussed most of this on the previous slide, but let's just go through it to see that we have this procedure well understood. So pre-procedure, okay, we're definitely going to look at the blood work, the labs. Okay, we're going to see what their CBC is, what their clotting status is, such as their INR. We're going to look at their platelets, because all of those can be abnormal with liver failure, right? So we just want to have a good idea before we start putting a needle into someone's abdomen. What is their clotting ability? We're going to get them to empty their bladder completely. If they have a catheter in, well, it's already empty since the catheter is draining the urine. We typically sit the patient upright as opposed to lying flat, since it's really difficult when they're lying flat because they're so short of breath. Recording the weight, abdominal girth. If they're really anxious, which typically they're not if you've properly frozen or anesthetized the skin. Okay, but if they are, we can always give them a benzodiazepine such as lorazepam or diazepam. Administering albumin can be done during the procedure, before the procedure, or even after the procedure. Either one, or any of those. Okay, during the procedure, we're going to monitor vital signs. We're going to anesthetize the area. We're going to put in a paracentesis needle after we've found a really good fluid area, which is typically the lower abdomen. And we're going to let it drain into bottles or a bag by gravity. And usually 4 to 6 liters, but as I mentioned before, it can be much more if we're comfortable with their blood pressure and their vital signs. Okay. After the procedure, we remove the needle. We put a bit of pressure on the site because it often just oozes peritoneal fluid. Monitoring of vital signs is still needed. Recording the patient's weight, well, it'll just tell us how much fluid was taken off, but we already know how much fluid was taken off because we've monitored the volume. Okay. Administration or starting of diuretics such as spironolactone or furosemide can be helpful in terms of slowing down the return of the ascites, and of course, so can the IV albumin. Okay, and then of course looking at the fluid itself. Okay. On the following slide, they're going to show you a paracentesis and the patient's lying flat. That is not a common way to do it because if someone has really massive ascites, there's no way they can lie flat. They're just too uncomfortable. But I still think it's worth watching though. Okay, so the complications of a paracentesis, which is really the removal of significantly large volumes of peritoneal fluid. The first one, so sure, hypovolemia and sometimes electrolyte imbalances, right? Because we're removing fluid that has protein and electrolytes in it. So there's going to be fluid shifts and we could cause hypovolemia and orthostatic hypotension. When they get up too fast, they feel dizzy and off balance. okay? And that's from low blood pressure. Okay, so, and that's one of the reasons why we administer albumin to try and offset the hypotension and orthostatic symptoms they can get, and also to slow down the reaccumulation of ascites fluid. Bladder perforation is really unlikely since we always get them to empty their bladder prior to the procedure. One other complication is peritonitis, and how can that happen? Well, we could inadvertently poke their intestine with the needle. So we go into the fluid, but maybe we went a bit too far, or there happened to be a loop of bowel there and we perforated it. And then, of course, there's leakage of bacteria into the peritoneal cavity, causing peritonitis, okay? Or we introduced bacteria from the abdominal wall because it wasn't done sterilely, which is, this is supposed to be a sterile procedure, okay? So either by poking the intestines or from not having done the procedure sterilely. And they present with abdominal pain, fevers. So we always tell people, if you develop severe abdominal pain or any fevers in the next few days, you need to return to CS. And probably the most common complication is leakage of peritoneal fluid from the puncture site because there's still pressure behind it. That's not a big complication, and as I mentioned before, sometimes we need to put a stitch there to stop the fluid from coming out. Okay, so let's just briefly talk about ostomies. So there's two types. An ileostomy is where we have gastrointestinal contents, so fecal contents that are diverted from the ileum or the small intestine, usually the ileum though, into to the abdominal wall, right? A colostomy is diversion from some segment of the colon. So whether it's the ascending, the transverse, or the descending colon. Okay, they can be temporary. And why would they be temporary? Well, say someone had a colon cancer, and they developed a bowel obstruction from the colon cancer, so they needed emergency surgery. They can't always reattach the colon back together once they've removed the colon cancer. So they have to create a colostomy and let some healing occur, okay, following the removal of the colon cancer. And then they'll go back in and have a second procedure where they'll reattach the bowel. So that's temporary. Some are permanent. So for example, someone who's had a colectomy, so removal of their entire colon, may have a ileostomy. So someone who has severe ulcerative colitis, where they just can't manage it properly, they may have an ileostomy since the entire colon was removed. Okay, so an ileostomy typically has liquid type stool because it hasn't made it to the colon, and likely the colon isn't there anymore. And one of the roles of the colon is to reabsorb fluid. So the fluid coming out of an ileostomy is typically quite liquidy. Okay, compared to a colostomy, it just depends on which part of the colon was diverted to the abdominal wall. So if it's the ascending colon, well, not a lot of water absorption has been done, so it's going to be typically a bit more liquidy. If it's the descending colon, well, a lot of fluid absorption has occurred, so it's going to be closer to normal stool consistency. Okay. Okay, so below on this slide is just explaining the steps in the care of some kind of ostomy, whether it's an ileostomy or a colostomy. So putting on a clean pair of gloves. Typically you drain the old pouch first, and then you remove the pouch, okay, once it's been drained of liquid stool. And then washing, just gently washing the skin around the ostomy with mild soap and warm water. Make sure that it's nicely dried. We apply a skin barrier to the peristomal skin, and then we apply a new pouch, right? So stomal care is really important, and there's actually nurses that do this full time. They take care and provide advice on the care of ileostomies and colostomies. Okay, so there's two images on this slide. So you can see there's quite a technique to changing the bag and reapplying a new bag with a proper fitting around the ostomy, right? And if you look at those two images of the ostomies, they're nice and pink. They have good color. They look moist. They're not pale. They're not black, which would indicate ischemia or the tissue is dying, right? So the skin around looks really good. Okay, so assessing an ostomy, whether it's a colostomy or an ileostomy, is really important. Okay, and one of the other considerations is, what is the patient able to do? Do they have decent vision to be able to do this themselves? Do they have good dexterity, manual dexterity? Are they able to reapply this themselves? Because many patients need help to do this, and it's not possible for them to do it. Okay, their cognition. So are they demented? Do they easily get confused? That's important to know. And what support systems do they have at home? What home care services will they need? Okay, and as I mentioned, there's ostomy care nurses that are very proficient in taking care of ostomies to prevent infection, to prevent skin breakdown around the ostomy. Okay, all of those things are extremely important. Okay, so let's talk just briefly about bariatric surgery, another type of abdominal procedure. So bariatric surgery is done for obesity, right? In the hopes of weight loss, because we know obesity is a stepping point for many complications in patients. So obesity leads to osteoarthritis, typically at the weight-bearing joints, such as the knees, the hips, the ankles. It leads to hypertension. And if it leads to hypertension, it's going to lead to cardiovascular disease, which is heart disease, atherosclerosis of the arteries of the body, ischemic strokes, renal failure. On top of that, obesity leads to type 2 diabetes, and type 2 diabetes also causes more hypertension, and it also leads to strokes and heart disease and renal failure. Okay, so obesity is if we can reduce obesity and have patients reduce weight, the hypertension, the cardiovascular disease, heart attacks, strokes, renal failure, diabetes can be much better controlled. Okay, so there are medications out there with varying degrees of success. One's called orlistat, which inhibits fat absorption. I would say that has minimal success. Most patients can't tolerate it because if you don't absorb fats, you get abdominal discomfort, abdominal cramps, and oily stools. Okay, not pleasant. If you don't absorb fats, you're also not absorbing fat-soluble vitamins, right? So they can become vitamin deficient. There's other ones. There's another one called lorcaserin that stimulates serotonin receptors in the brain to suppress appetite. Okay, and there's another one mentioned in your book. Not overly effective, and that's why bariatric surgery has become more and more common. Okay, And there's two main categories of bariatric surgeries. There's restrictive procedures, where they're doing a procedure that's going to reduce the capacity to accept food into the stomach. Okay, that's the whole aim of a restrictive bariatric surgery. Compared to a malabsorption surgery, where they're purposely trying to interfere with the absorption of food and nutrients from the gastrointestinal tract. Okay, and these tend to be more effective. A lot of patients maintain the weight loss that occurs at the beginning for years later, because they're just not absorbing the nutrients. Okay, compared to the restrictive surgeries, which is limiting the amount of food that they can eat, but typically the weight loss that occurs at the beginning tends to recur. Okay, they tend to gain back their weight over time. And some bariatric surgeries are a combination of restrictive and malabsorptive. So let's look at the first one. So gastric banding. So this is a procedure where they put a band around the upper stomach, and that line you see, so it's the first one there, that line that you see goes to a port just under the skin, and the port can be accessible to pressurize that band that's around the upper stomach to make it tighter, or if it needs to be adjusted, it can be loosened off a bit. Okay, so it's just a restrictive type of surgery. In some countries, these have been banned because sometimes what happens is that loop that you can see in the upper stomach there slides upwards and chokes off the esophagus, which of course makes it impossible to swallow. So patients come in really uncomfortable, they're drooling because the esophagus is now being compressed. Okay. Anyways, that's gastric banding. The next one, vertical sleeve gastrectomy. So you can see that a portion of the stomach has been resected, and it's created a smaller volume in the stomach. Okay, and by doing that, you now have a smaller volume that can accept food. Okay, so let's look at some post-procedure considerations. So first one, so these are complications. The first one is hemorrhage. So remember, this person has undergone a surgical procedure, um, bypass, incising and cutting parts of the stomach. So bleeding can occur. So acute bleeding, how do we know that? Hypotension, tachycardia, abdominal bloating, abdominal pain. If they're hypotensive, they may be confused, altered mental status, okay? And they may need transfusion. Plus, they may need for someone to go in to the abdomen to stop the bleeding. So laparoscopically or an open procedure. What about a leak? So an anastomotic leak where the bowel was connected to another part of the bowel. That's pretty serious if it's leaking, because bowel contents are leaking into the peritoneal cavity. So they can develop back pain, abdominal pain. If it's irritating the diaphragm, shoulder pain. They're going to become tachycardic, hypotensive, because they're developing peritonitis. And if you're hypotensive, you're going to have decreased renal perfusion, which is going to cause less urine production, so oligouria. Okay, so this is definitely an emergency. This may need not only IV fluids, but a laparoscopy, meaning to open up the abdomen. Well, laparoscopically, meaning with scopes. Okay. An abscess can form in the abdomen, right? So this isn't. There's always a risk of infection, so the area can become infected, which could lead to peritonitis, or you could get a collection of pus called an abscess. You can develop strictures, right? And strictures can occur where the bowel has been reconnected during these procedures. And of course, if there's a stricture, food and fluid aren't going to flow properly, so you'll get backup of fluid that will very likely lead to vomiting, abdominal pain, right? And that may need to be corrected with endoscopy, so a scope into the mouth and down into the stomach looking for a stricture. Gastroesophageal reflux disease can occur, right? And patients often need a proton pump inhibitor because of the GERD symptoms that they develop. Nutritional deficiencies can occur, and these are more chronic symptoms now. So strictures, GERD, nutritional deficiencies can occur. Now, if the patient has an NG tube down after surgery to suction stomach contents, to avoid repositioning it, because there's sutures that are holding the different bowel segments in place, so not to move the NG tube would be a good idea. Okay. Monitoring for post-operative complications from any surgery, so whether it's skin breakdown, atelectasis because of poor inspiration, so they need to take deep breaths. Often they're given an incentive spirometer to take deep breaths. DVTs, so thromboemboli, so DVTs or PEs, so they'll often need compression stockings. Monitoring for peritonitis in this case because it's abdominal surgery. Okay. Assessing O2 saturations and airway, very important, right? So they wouldn't be kept in a supine position, at least semi-Fowlers, to encourage good lung expansion. Okay. Now, it's important to get these patients up as soon as possible, like most surgeries, so encourage ambulation because it minimizes post-op complications, right? So fluids, to resume fluid intake as prescribed. So typically, very small amounts of fluid are attempted, so 2 tablespoons, and then gradually increased throughout the first day, okay, to see if they can tolerate liquids. Patients with gastric bypass surgeries usually have small meals but more frequently, so 5 or 6 small meals throughout the day, and to watch for what's called dumping syndrome, which is where just too much food is being introduced into the small intestine, and they get this hyperosmotic reaction where fluid just pours into the small intestine, causing abdominal cramps, diarrhea. It can cause hypotension and tachycardia because all this fluid shift. Okay. Post-operatively, patients usually need to stay on liquid diets or pureed foods for the first month and a half. And they're highly encouraged to walk daily or some kind of light activity daily for at least 30 to 60 minutes. Overeating is definitely discouraged because it can dilate pouches, and it can actually tear through staples if staples removed, right? Sometimes patients need vitamin and mineral supplements because they're not getting enough nutrition and vitamins in. Okay, so they can become vitamin deficient. Okay, under complications, so dehydration for sure can happen. And how can someone monitor for that? So dark, concentrated urine or excessive thirst can be an indication of dehydration. Malabsorption and malnutrition can occur because you're either reducing the size of the stomach or you're bypassing parts of the gastrointestinal system. Okay, so monitoring the patient's intake of food and fluids. They may need a referral for dietary advice. Encouraging clients to consume meals in a low Fowler's position and to remain in this position for 30 minutes after eating. And what that's going to help with is just to slow down the food that's arriving into, say, the pouch, the stomach. It's going to slow down stomach emptying and reduce the chance of dumping syndrome. So high nutrition food is encouraged, right? So empty calories such as pop, very sugary drinks, they're not really encouraged, and also they're going to potentially cause dumping syndrome. Okay, so this is just a bit of an introduction to bariatric surgery. I hope that helps. Okay, so let's do the questions at the end of chapter 47. Okay, so number 1, a nurse is caring for a client following a paracentesis. Which of the following findings indicate the bowel was perforated during the procedure? Okay, so it is possible for that needle that we're putting into the peritoneal cavity to drain the fluid to potentially poke a bowel segment. So let's look at the possibilities here. So what findings would indicate that? A client report of upper chest pain. No, that's not where the procedure is done. It's typically done in the lower abdomen. Decreased urinary output. No, that's not specific enough to really be helpful with this complication. Pallor. No, pallor is a symptom of anemia. So I don't think that's going to help. Temperature elevation, so a fever. I'm not sure why they don't just say fever, but temperature elevation is close enough, so that's definitely an indication. So abdominal pain and fever would be a concern after this procedure. So the answer is D. A nurse is planning care for a client who has a new prescription for TPN. Which of the following interventions should be included in the plan of care? Okay, obtain a capillary blood glucose 4 times daily. That's definitely a good idea, right? Because TPN has a lot of carbohydrates, and it can cause hyperglycemia. Okay. Administer prescribed medications through a secondary port on the TPN IV tubing. No, TPN should have a dedicated IV tubing to itself, and not to have ports to introduce medications. That would be incorrect. Monitor vital signs 3 times during the 12-hour shift. I think that's reasonable. So that would be every 3 to 4 hours to monitor. To monitor vital signs would be reasonable. Okay. Change the TPN IV tubing every 24 hours. Yes, at a maximum, right? So TPN tubing should be changed. Remember, it's food, it's nutrition, so bacteria can potentially grow in it. So the tubing and bag are changed. So D is an answer. E, ensure a daily PTT is obtained, which is really for heparin. So no, we wouldn't need a daily PTT at all. TPN doesn't thin the blood, so that's not necessary. So the answer is going to be A, C, and D. Number 3. A nurse is providing care to a client who is 1 day post-operative following a paracentesis. The nurse observes clear pale yellow fluid leaking from the operative site. Okay, that can definitely happen, just dripping of fluid from where we punctured the abdomen. Which of the following is an appropriate nursing intervention? Place a clean towel near the drainage site. Apply a dry, sterile dressing. Apply direct pressure to the site. Place the client in a supine position. So, I don't really like this question. I would say it's going to be B. Apply a dry, sterile dressing to the site, which is just going to allow the fluid to be soaked up into the dressing. Okay. Apply direct pressure to the site. That's not unreasonable. Could it cause a bit of discomfort to the client? It could, but it might also help stop the leak. And sometimes, really, after applying a sterile dressing, and we notice that it's just soaking through the sterile dressing, we'll just put a stitch in to stop the dripping. Okay, so it's not a big issue, and it's not really like you can apply direct pressure for a long time anyway. So the answer is B here. But also remember, sometimes we have to put a stitch in, or even we'll put skin glue to just close the little puncture. Okay, so the answer is B. 4, a nurse is completing discharge teaching with a client who is 3 days post-operative following a transverse colostomy. Okay, transverse colon colostomy. Okay, which of the following should the nurse include in the teaching? Mucus will be present in stool for 5 to 7 days after surgery. I don't think that would occur. Okay, I don't see why you would have mucus for 5 to 7 days after surgery. Expect 500 to 1,000 mils of semi-solid liquid stool for 2 weeks. I think that is incorrect as well. That would be more in keeping with an ileostomy, where you're having half a liter to a liter of liquid type stool. Okay. Remember, a transverse colostomy or will typically start to have formed stool compared to an ileostomy. Okay, so C, stoma should be moist and pink. Absolutely. Okay, it should look moist, pink. It's usually raised a bit above the abdominal wall so it fits well into the bag. Okay. Change the ostomy bag when it is 3/4 full. Typically, you don't want to wait until it's 3/4 full. Usually more around half full. Otherwise, you're risking the bag just breaking off of the area and there's just stool everywhere. So that's not a great idea. Okay, so the answer is going to be C. 5. A nurse is caring for a client who is receiving TPN solution. The current bag of solution was hung 24 hours ago and 400 mils remains to infuse. Which of the following is appropriate action for the nurse to take? Remove the current bag and hang a new bag. Okay, well, that is going to be the answer because you shouldn't really have it hanging beyond 24 hours, right? Infuse the remaining solution at the current rate. No, it's been there 24 hours, it needs to be removed. C, increase the infusion rate so the remaining solution is administered within the hour. No, again, And you don't want to infuse the remaining solution. You need to remove it because it's been 24 hours. Remove the current bag and hang a bag of lactated ringers. No, you wouldn't do that. Lactated ringers, by the way, has no sugar in it, no dextrose. So there would be a good chance if you did that, the patient would become hypoglycemic. So it's really just a matter of changing the bag to a new bag, okay? And again, because it's food, it's liquid food, there's a risk of developing infection.